on. Hi everyone, good morning to everybody. Okay, thank you.
vice presidential candidate of the People's Democratic Party. We welcome also all executive of the Delta State management. We also welcome Chief Benjamin Elue, the former Deputy Governor of Delta State. We welcome Dr. Kingsley Emoe, the Chief Economic Advisor to the Delta State government. We welcome Honorable Dr. Anyanwu, the Honorable Commissioner of Information, Delta State. We also welcome Barrister Guru Uzurum, the DG of the Delta State Orientation Bureau. We also welcome the Director, the Chairman of the Delta State Contributory Health Commission, Dr. Isaac Abofeta here, and also the CSOs, partners, donors, and also the Country Director of Pharmacists Foundation, Njide Ndili. All protocols observed, and if we have every other name missing, please, I look forward to having them so you'll recognize them fully. To move the event, I'm going to invite Dr. Olumide Kokola to come and give us a general introduction and background to this laudable initiative in partnership with Delta State and Pharmacists Foundation on revitalizing primary health care via public and private partnership. Once again, we welcome our online audience. Thank you for staying with us. Apologies for keeping you waiting, and I'm sure you're going to have a wonderful event. Welcome, Doctor.
Hello. Thank you very much, Samto. There's a round of applause for everyone here this morning. You're very much welcome. So, it's very delayed. It's universal health coverage journey. As you all know, and maybe for those who are not from our sector, universal health coverage is when every country in a geographical area has access to affordable quality care without suffering financial catastrophe. As I said earlier, Nigeria is pretty much delayed on its UHC journey. But then several countries have also shown how they, and it's really a delight and pleasure to see that innovation is being taken to scale in part of this country. And that's why some of us are here, associate, and also learn from what I will call the Delta story. In healthcare, you could conceptually look at having a supply side. Demand are those that accessing health care, most health, or within the community. Is health infrastructure. Nigeria, we have problems on both sides of the equation. But there are a whole lot of reforms trying to address the financial barriers. Have the massive reforms going on the Nigeria Health Insurance Committee, President Law, the Mandatory Act a few months ago, and that is a significant step for Nigeria in its UHC journey. So clearly things are happening on the demand side. Where the supply side of things. Nigeria has infrastructure. At the last count, there are about 30,000 public PHCs. What we do not know is the functionality of those PHCs. And I believe what we will be hearing over the next 2 hours or so is how to change the trajectory. I do not want to be ahead of myself. I would have said we give a round of applause to the team for what they. I think at some point I'll be making a presentation, but okay, fine. So I'll just make it. I won't even share slides. Okay. So essentially, like I said, the role of the private sector in health on the private, helping to resolve constraints on the supply side is something that we have been seeing across Nigeria. And you could describe this in 3 archetypes. First is where members of the community, philanthropists, will say, my facility is not working, and I want to take over this. So you have the Kola Daisy Foundation running a number of public PHCs, the Tulsi Chanrai Foundation running a number of PHCs. That will be one archetype. A second archetype is where the public PHCs will now be taken over in part or in full by the private sector. So it's not unusual for us to see public facilities having laboratories outsourced to the private sector. The third, which is a bit more challenging, is the one where the government of the day, either the local government or the state government, in recognition of challenges to say, look, I have fiscal constraints and there's probably a better way to spend the limited resources I have. For instance, my money on the demand side of things, where I cover my people with insurance and I outsource the facility. We saw this in Mowe, Ogun State, and we supported a number of states to develop working with Farm Access Foundation, because we know that it will be a challenge for the private sector. Hello. We know it will be a challenge for the private sector to raise capital and make these facilities functional. The states that we expected to even take on board this framework sadly did not move as fast. A few years after we developed this framework, we had a new leadership emerge in Delta State. We engaged with them, and lo and behold, in about a year or so, we had this framework implemented. What are the elements of this framework? The first is there needs to be policy in place to say these buildings belong to government. But because it belongs to us doesn't mean that we have the capacity to run it. So you have the PPP laws in the states. And second is you need to also make sure that you have your people who are going to access care from that facility have the financial resources to do so. Where poverty is high, then you know that you need to fund the access of those people through government resources. The policy to address that will be to put in place a public health or social health insurance program. The third is you need to reassure the private sector that this is something credible and worthwhile to do, and that the sanctity of the contract that binds you and the government. I might have described these 3 elements off the top of my finger, but this takes time, it takes commitment. Even the private sector to do this is not really a joke, especially in a state like Delta. Delta was able to tick all of these elements. In fact, the ability to have people who normally would not have been able to access care go into a facility run by the private sector without having to think of paying out of pocket, I believe is an innovation that all Nigerian states would need to emulate. I believe it's not for me to be ahead of all of the presentations, but it's just lay the ground for what are the things we look for in a collaboration like this. And I believe that if many other states and many other of our public policy makers begin to think out of the box innovatively, then our supposedly bad health outcomes, which are truly bad, can only
said, well, let's see how we can bring in private sector. Let's think out of the box and do something different. We know that primary healthcare center functionality and operation is a function of the government. But in a situation where you have some that are non-functional, with weeds growing and so on, can we bring in private sector with their money, with some governance, efficiency, transparency, and so on? And let's just test it. So we started with about 15 facilities. And you will hear, this is just a short story. You will hear some of the outcomes and some of the schemes, and you will also get the report, which will give you the history of how this started. So it was a long and treacherous journey, I must say. Some into the creeks of the Niger Delta with armed security and so on. I mean, facilities as far out as 3 hours by speedboat, one way. It's really inspirational, I must say. So what had happened is that we then started discussions with various parties, the Bank of Industry, Medical Credit Fund, the Healthcare Federation, everybody playing a different role, but most especially the communities, the community leaders. So I must thank you for your support and your participation in the program, because without them and the political will of His Excellency Governor Okowa was none, second to none. There are some critical success factors to this scheme, which I'm sure as we're making the presentation, you would hear about some of them. One is this political will I talked about, having the belief and having the champions within the state that will lead it. Even as we're talking about farm access supporting, we are in the back supporting, but the state is leading this, especially with the leadership of Dr. Ben Nkechika. So please, a round of applause for him. The second critical success factor, which we also want to emphasize, is the quality, which we talked about, having quality within the clinics. And just even to step back and explain why the name of this scheme is access to finance, because it caused a lot of problems. Because initially the name access to finance in another state where we wanted to implement, it was seen as, maybe distribution of funds or something totally contrary to what we were trying to achieve. Access to finance was a mechanism for private sector to access finance to be able to revitalize or get healthcare systems functional. As we all know, it's extremely difficult for healthcare providers to access finance through the regular financial institutions. They ask for all sorts of documentations, and we know that healthcare facilities are usually the right structures or continue to help enable that and facilitate the access to finance. So there was a lot of discussion, even with Bank of Industry, to waive some of their requirements, to reduce their, the amounts that could be received as loans and so on. Then stepping up also to Healthcare Federation, the fact that we needed a transparent body that could speak with one voice on behalf of private sector and the role they can play, not just in this program, but also going forward. The private sector has a very significant role to play. Government can't do it by themselves, especially now post-COVID, where the resources have diminished, and where we need to bring in and always think out of the box on how to bring in innovation. The third thing is the issue of technology. Technology, and I'm sure Dr. Ben will talk about that, is also a critical success factor in this case, because he's able to track the funds, track the utilization, and so on and so forth, to the extent that a lot of the implementation of the scheme is electronic. That again is a critical success factor. So I want to, not to let the cat out of the bag, but I think I will crave our indulgence to listen intently, because we've taken the highlights from this impact evaluation. And the reason why we had to do this study is because it's an innovation. It's never really been done in the way that we have done it. And it's important to document the learnings and the best practices, which is why we're here, to share them. We didn't get it right from the get-go. There were a lot of iterations. We changed a lot of things, we improved, we got feedback, also from the providers of things that were not working, also on the government side, the things that they needed to improve, and so on and so forth. So I would say I'm excited for us to keep an open mind. I'm also happy Senator Dr. Loriebe just stepped in, because we need policymakers also at the federal level to think with us and think out of the box and see what we can adapt and adopt, especially in light of the new bill that has been passed, the NHIA bill, which now makes health insurance mandatory. Question now will be, where would people go? So having said that, I would like to say thank you very much for taking our time, especially those online. We will be making the report available for all those who are in attendance, but there's a lot of learning from what we've experienced in the last 3 years from this evaluation. So thank you very much.
Yeah, thank you very much. Resounding. Okay, just before we proceed, I would also like to recognize the presence of the Senate Committee of Health, Senator Ibrahim Olorebel, who just walked in. Thank you. And I also want to recognize online, I think the Managing Director for the Medical Credit Fund, I am Powells. He's joined us online. Thank you. So the next line of introduction to Delta State. Now we've heard from one of the parties that initiated this laudable program, but we also want to hear from the party. And let me invite to the podium a key personnel who made this happen amongst every other person. The board chairman for the Delta Contributory Health Commission, my senior uncle, Dr. Isaac Apovete. Please welcome to.
Please, to avoid complicating issues, may I increase your indulgence to stand on the existing protocols? Thank you. Good morning, ladies and gentlemen. It is my pleasure to welcome you all to this August gathering, though on the 1st of September. The unveiling of the impact assessments of the Access to Finance program of the Delta State Contributory Health Commission, an innovative program to advance universal health coverage, especially to the hard-to-reach areas, to reactivate abandoned and moribund health facilities through private-public partnership. Before I conclude my simple assignment of welcoming you, that's all I'm supposed to do here. To today's event, I would like to create your indulgence to allow me to give a synopsis of the commission. A vision, and the commission was batted in December 2015. The visionary is no other person but the renowned current governor of Delta State and the vice presidential candidate of the PDP, Senator Dr. Ifeanyi Okowa, hereby represented by the SSG Secretary to State Government of Delta State, Mr. Pat Booker. You're welcome, sir. 7 years ago, he envisioned a Delta State where everyone will be healthy while financially protected so that prosperity will envelop the Deltans. That's when the commission was born. Today, 6 years on, the commission has blazed the trail to be the first among equals in state health insurance implementation. I mean, the regress here, Delta State is #1 state health insurance organization in Nigeria as of today, with enrollees up to 1.2 million. About 25% of the population of Delta State. Even the National Health Insurance Scheme have not achieved 25%, even 10%. I think we should give a clap to Delta State. In less than 5 years of clinical operation, deploying unique and innovative operational systems and programs, one of which is the Access to Finance program. This innovative program, conceptualized by Pharmacists Foundation, operationalized by the Commission, technically supported again by pharmacists, and financially managed by Bank of Industry, BOI, is first of its kind in Nigeria. The impact has been tremendous. We hope the country will adopt and adapt it nationally. One of the hidden impacts of this innovative PPP program is its reversal of the brain drain of the health sector workforce. Delta State have been able to stop some doctors from going abroad, come to Delta, not just coming to the capital, Warri, Sapele, Benin, but going to the creeks where they are treating those who really need health care. It's a unique occasion, and I think it's adopted and adapted by the country. A lot of our doctors going abroad looking for money, they will get the money in Nigeria here. Ladies and gentlemen, before concluding my very short welcome address, I would like to say that the great achievements of the Commission couldn't have been possible without the vision and the strong political will of His Excellency, the Governor of Delta State, Excellency Dr. Ifeanyi Okowa, who created and inaugurated a political board with public-private mix of directorship. The chairman of the governing board, Olusegun Dr. Isaac Apoveta, and the DG CEO of the commission are from the private sector technocracy, the very first in the country. Now, I want to explain this so that others can emulate it. Dr. Ben is a specialist in health system management, a private sector operator, probably have not really worked in government. Dr. Apoveta is also of that group and have not really worked in government. But His Excellency was able to look for, capture us from the private sector, move us into Delta State, and created a board and made us the head of this board and commission. In that board, we have very unique, it's not a matter of data central, data south, or data north. He picked those who really matters in health sector. The labor, Nigerian Labour Congress represented, NGOs represented, National Health Insurance Scheme represented, rather than picking politicians from the nook and corner of Delta State that will fight over, it is for my people, it's not for your people. But here, these are people that are fighting for the cause of the, and the broad of the commission members that are here present, stand up for others to say. Thank you very much. They work in serious conjunction with Dr. Ben. We discuss issues seriously, and we approve. And thank God we have a dynamic, hardworking, sleepless young man, not too young, he's gray-haired already, that implement night and day. Can tell you by 2 a.m., 3 a.m., Ben is still working. Anywhere he is in this world. Please give a hand of applause to him. It's my young brother that made me very proud. I welcome all of you here to listen to what he has done. We are policymakers, he is implementer. We can make a policy, and if it's not properly implemented, there is disaster. Thank you, Ben, and thank you all of you for coming to listen to us. We are grateful.
Thank you, Dr. Prophet. I hope I'm also your younger brother and also making you proud too. So thank you so much for that wonderful presentation. So while Doctor was giving us the introduction of the Access to Finance program, some special people house walked in. So please permit me to welcome the representative of the Honorable Minister of Health State, Dr. Onyinye Nwankwo, who is here representing the Honorable Minister for State. We also welcome the Professor Nasiru Sambo, the Director General of the National Health Insurance Authority. You're welcome, sir. Dr. Sambo has been on the forefront of ensuring that all Nigerians have access to quality and affordable healthcare, championing the UHC message. Thank you so much for joining us, sir. So we move forward with today's event. Permit to welcome the representative of the Executive Governor of Delta State, His Excellency Senator Dr. Ifeanyi Okowa, Mr. Patrick Walker, the Secretary of the State Government, to come and give us remarks. Thank you.
Representative of the Honorable Minister, Honorable Commissioners, Chief Economic Advisor, top government functionaries present here, our own former Deputy Governor, organizers of this event, please permit me, other distinguished ladies and gentlemen, it is with great pleasure that I join you today as a special guest representing His Excellency, Senator Dr. Ifeanyi Okowa, the Governor of Delta State, and by the grace of God, the next President of the Federal Republic of Nigeria, Vice President of the Federal Republic of Nigeria. His Excellency would have loved to be here personally, but for exigencies of duty, he has asked me to stand in for the Delta State government. Ensuring access to quality healthcare service delivery across all parts of Delta State has been a significant part of the administration's smart agenda under the relevant health and education policies. The Delta State Contributing Health Scheme thus became a major and early policy direction of the government as it's being implemented as a healthcare financing mechanism to ensure access to quality and affordable healthcare services for all residents of Delta State, irrespective of their geographical location and socioeconomic status. Delta State is fortunate to have had past administrations that invested in healthcare infrastructure to fully operationalize these facilities for the benefit of the people. There was the need for a viable and sustainable healthcare financing mechanism that enables the people to have the healthcare access when they need it without an associated financial burden. The administration of His Excellency Senator Dr. Ifeanyi Okowa has not only established a healthcare financing mechanism, but has also enhanced the healthcare infrastructure status of the state. Several healthcare infrastructure developments have been embarked upon and completed, with some at the final stage of completion. Delta State Healthcare Financing Mechanism was designed to ensure availability of adequate resources to capacitate the healthcare providers to deliver quality healthcare services and availability of resources to ensure that all Deltans are able to afford and access the healthcare services they need, especially for the poor and the vulnerable. The Access to Finance program is a testimonial for this healthcare financing mechanism, and we are appreciative of the support of Farm Access Foundation and the government of Netherlands towards the success of the program. The Delta State Contributing Health Scheme, which commenced service on the 1st of January 2017, currently has over 1.2 million enrollees with 20% population coverage, the highest in Nigeria. The scheme has also received awards and recognitions, both local and international, as the best performing state healthcare insurance program in Nigeria. The Delta State government will continue to support partnership that are conceptualized, designed, and implemented to enhance service delivery in Delta State for the benefit of all Deltans. On behalf of His Excellency, Senator Dr. Ifeanyi Okowa, the Governor of Delta State, I thank you all and wish you the best in this program. Thank you.
Thank you very much, Chief. Thank you so much for that message. Permit me to also recognize Mr. Michael Dellin, who is the Consul General of the Embassy of the Netherlands, Lagos. He's been online, listening to us, and very soon we'll have a goodwill message from him. So the next is to introduce the Honorable Minister for State, Honorable Joseph N. Ekama. He's represented by Dr. Onyinye Nwakama, who will be giving us a goodwill message from the Honorable Minister. Thank you.
Good morning, ladies and gentlemen. Excellency Senator Ifeanyi Okowa, representatives, the state, the SSG, the Director General, National Primary Healthcare Development Agency, and all other protocols duly observed. My name is Dr. Onyinye Nwankwo, and I'm here representing the Honorable Minister for State Health, Dr. Barrister Ekumankama. Actually, the minister is very delighted to be invited to this program. The Honorable Minister for State was very delighted. In fact, up until last night, he thought he was going to be here present because this is one of the things that is very dear to his heart, health financing and, universal health coverage is very dear to his heart. So he was supposed to be here, but up until last night, he got a call and has to be unavoidably absent. Please bear with him. So actually, he asked me to represent him and actually convey his excitement on this program. Because actually, the government cannot do it all for us. The government cannot do everything for us. So this is a very laudable program, partnering with private sectors, the public-private partnership is very important in this program to get universal health access to everybody. This thank God the DG, National Health Insurance Agency, is here. It was established in 1999, with a view to achieve universal health coverage in Nigeria. But up until now, very few persons are still covered. So this program actually, with Farm Access and the Delta State, you've actually heard a lot about this program, and it's been, it's been going on well. And they've used it to achieve a lot of coverage for even the underserved communities that are in Delta State through the primary healthcare, hospitals all over the place. So he asked me to convey his goodwill and to ask you to continue the good works you have been doing. And he says that, the Federal Ministry of Health is poised to partner with you, that's Farm Access, and any other states, who is willing and who wants to, spread the universal health coverage for their citizens. We are very much poised to support and to lend, all the technical support that we can muster to help them to achieve the universal health coverage. So with this in mind, he wished to he wished to, congratulate you on the success of the program so far, and to tell you that he is here with you in spirit, though he's not here physically, and that the program can go on, and you feel free to reach him at any time if you want some issues tackled, some questions solved, and to get things going. Thank you, and God bless.
Thank you so much, Dr. Onyinye. So we move straight to a man who has been working tirelessly day and night, ensuring that Nigerians have access by the National Health Insurance Authority. I'm going to invite Professor Nasir Sambo to come and give us our goodwill message.
The distinguished senator and chairman House Committee, chairman Senate Committee on Health, Senator Ibrahim Olorogbe, the representative of the Honorable Minister of State, the representative of the governor of Delta State, ably represented by the Secretary to the State Government, other respective representatives from Delta State Government, the chairman board, Delta State Contributory Health Commission, the Director General, Delta State Contributory Health Commission, the Country Director of Farm Access, and other members of our team, the Access to Finance team, and the stakeholders, other partners from the World Bank, distinguished ladies and gentlemen of the media, good morning. It's my pleasure to be invited to this very important occasion and to deliver a goodwill message today at the Delta State Access to Finance Scheme Impact Study Dissemination event. I'm reliably informed that the Access to Finance is an innovative program based on public-private partnership to revitalize primary healthcare facilities, especially hard-to-reach and underserved communities. It also adopts a comprehensive approach by strategically linking the demand and supply sides, harnessing public-private sector participation, focusing on primary healthcare, and improving access to vulnerable populations. This approach is important for the attainment of universal health coverage and the National Health Insurance Authority operations. And therefore, NHIS is highly committed to the goal of this and the objective of this activity. The NHIA Act 2022, which was a landmark law ably driven by the Senate Committee on Health, specifically Dr. Ibrahim Olorogbe, who sponsored the bill and ensured that the bill came into fruition. After several attempts to do that, and finally became a reality. Within that act, there is a provision of establishment of vulnerable group funds to mobilize additional resources for financial access to quality healthcare for the poor and the downtrodden Nigerians. It is on record that even before this act was signed into law, NHIA had made significant effort to improve health insurance coverage in Nigeria by spearheading the decentralization of its activities at sub-national level through our state offices. It has also been a leading agency in operationalizing the National Health Insurance Authority gateway of the Basic Healthcare Provision Fund, among others. While many of the states and federal capital territory have successfully set up social health insurance agencies, and are providing financial access to the vulnerable population using NHIA Gateway, Delta State is one of the few states that has continued to stand out as a beacon of excellence. This is a testimony of the visionary leadership of the Executive Governor, His Excellency Senator Dr. Ifeanyi Arthur Okowa, the vast experience of the board chairman, Dr. Isaac Afobita, and the tenacity of the Director General of the State Contributory Commission, my very good friend, Dr. Ben in Kechika. It is also important to reiterate the partnership between Delta State and Contributory Commission and the National Health Insurance Authority did not start today, as from the beginning, the NHIA played an active role in drafting the Commission's enabling law, supporting its subsequent implementation, and facilitating its collaboration with other stakeholders under the platform of our innovation health insurance under our roof. The success of Delta State collaboration with Palm Access Foundation on the access to finance scheme is also not surprising. Palm Access Foundation has collaborated with some states and other stakeholders within the health sector to build technical capacity and co-create solutions to development challenges, taking local context into consideration. I'm therefore happy that today you will be sharing some of the evidence generated and lessons learned from the collaboration. Let me also stress that working with evidence is very important to us as the National Health Insurance Authority. It is one of the elements of the second of our 3-point rebranding agenda within the ambit of transparency and accountability. In addition, myself as a university professor, an avid researcher and policymaker, I have no option than to place a high premium on evidence for learning, planning, policy formulation, and decision-making. That is why I had to shelve other very pressing commitments to be with you here to know exactly what is going on and also learn and collect some of the evidence that will help us to continue to improve the situation in the National Health Insurance Authority. It is my fervent hope, therefore, that this study will not only add to the body of knowledge, but also to serve as a reference for future public-private partnership to improve the well-being of good people of Delta State and indeed all Nigerians. I thank you very much for listening, and I wish you all a successful event. Thank you. God bless you.
Thank you so much, DG. Thank you so much for that wonderful goodwill message. So we'll move next to the next goodwill message from one man who has been in the forefront of ensuring that the Nigerian have access to quality and affordable healthcare at the legislative chamber. Permit me to welcome Dr. Ibrahim Norebe, who is the chairman of the Senate Committee on Health.
Thank you very much. I will have just copied Dr. Popeta to say I align with the existing protocol, but I dare not do that because the Delta State governor happened to be, we have crossed our paths in many ways. It was my predecessor in office, was the chairman health committee of the 7th National Assembly. And significantly, it was while he was chairman of that committee that we had the National Health Act passed. Very significant because today, one of the game changer in primary healthcare in this country is the Basic Healthcare Provision Fund. It took us 10 years to get that act passed. It was only when it was there. So I recognize him. I won't say in absentia because he's here, because we have the Delta State government is here. I would reluctantly say I recognize the ministers of health, and I have that right to say ministers pass through us. We approve them. They bow before us. These are very important occasions that we expect ministers to attend in person, not to say representative. because one of the functions or the main functions of the ministers are to ensure that we have good health in Nigeria. And primary health care, I know, is core, and I know the minister is very passionate about that. Several times we have had discussions. So I expected the minister to be well represented in this. So I would say, because Minister of State and Senate representative will recognize them. I do recognize my friend and my colleague, Professor Sambo, the Commissioner of Health, Delta, and all the Delta state team, particularly Dr. Ben, and Dr. Profeta. I've had the opportunity of being in Delta to visit the agency. So as such, when pharmacists sent me invitation, I said I must be here because I've seen what they have done, and they have pioneered several things in that. I was there, I think, in the year 2020 or thereabout. So, and then we had a very thorough visit. I saw how they are pioneering. For example, I'm sure you have gotten briefing from them on the e-health thing. They invested quite a lot of resources to be able to have all their enrollees captured with very good card, and they link even that card to finance, to their banking system. So it's something that many states need to look at. So having done recognition, I'm pleased to be here, and I want to pick from what Professor Sambu said. I'm here to be able to also listen and learn. I'm not a university professor, but I'm a student of health research, because that's what I used to before coming to this position. So any opportunity to be able to listen to evidence that will improve planning and policy, I'll be very happy to be there. But we have not seen the nitty-gritty and the process. But from the introductions I've had, from personal practical experience, most of my practicing life was in the private sector. I left as an employee in Kano in the private sector to establish a practice in Ilorin in 1996. I remember I had to look for resources to back my personal resources. So I had to take loan from Trade Bank then. It was a very tedious. I was able to get the loan because of the personal guarantee of the then chairman of the bank, who was the former chief of staff, General Abdullah Mohammed. Knowing me personally, being from the sector, he guaranteed it. Otherwise, the only thing I could use as collateral was the clinic. Of course, they still say I should use the equipment in the clinic and the building which I own. So, but the process was very tedious. So listening today, without knowing what is the detail, to making access to finance to private sector, to private practitioner is very important. But more important, which I've been told when we were in Delta, was that the facilities were carefully selected to be at the out-to-reach and unaccessible or unattractive facilities in which ordinarily private sector will not want to go there. And that's for us to be able to achieve UHC, we need to have access increased. Now, the other one that I'm interested to know is because, and I'm sure somebody will also be interested in that, for us to learn how the public and private sector, there's always this fear by the public sector to give finance or access to private sector because the interests are different. The public sector interest is about giving services at no cost and so on. Whereas a private sector, the motive will be profit at the end, because that's what we call the bottom line. So the two have to be able to meet. And because the public sector intends to cover everybody, it must look for everywhere. And because the public sector cannot be everywhere, because government, as we know in this country, even if you put facilities in some places, you may not be able to attract human resource to those places. This is a challenge we have in this country. Both across, not necessarily, Delta has peculiarity of riverine area where you have cliques and so on. But in every other state, you have rural areas where doctors, nurses, and other health workers will be afraid to go because they think of their children. Which school would they go? Which market would they go, and so on. So, except there is an innovative way of attracting these people to be there, we won't be able to provide services for them. So, I'll be very much interested to know this and to learn. And then we will be, at the end of it, the final point I want to make is that we hope, learning from this, we can see how that lessons can be spread or can be shared across the country and inform policy and legislative changes that will increase not only access to health, but the financial access, but all the three accesses that we know, and enable us to achieve universal health coverage. On this note, I thank you for inviting me, and I look forward to listening. Thank you.
Thank you so much, Senator. So we move to our online audience, and I have to also thank them for being patient with us. And also we have one of our greatest supporters, people that ensure that pharmacists keep doing the wonderful work in Nigeria and also beyond. And permit me to invite Mr. Michael Delling, who is the Consul General of the Embassy of the Netherlands, Lagos, to give us his goodwill message. So he will join us online.
Good morning. Can you hear me? Good morning, Your Excellencies, ladies and gentlemen. Allow me to stand on existing protocol. I've been listening with great interest to the previous speakers, and it just shows that with a lot of perseverance and political will and the different entities involved, you can actually achieve remarkable results. And I say remarkable because obviously we are doing this, as was also mentioned, for those who are underserved, for those who have not really access to primary health care, and that's actually the group that needs it the most. The Netherlands is very honored to be associated with this event and with the presentation of the Delta State Access to Finance Impact Evaluation. It's as I said, it's a project that has shown to us, both in Nigeria, but also across borders, that if you sit together with the different stakeholders, you can achieve these results. Myself, I'm not a doctor. I'm a simple lawyer by background. And if you ask me what is a clinic, I would probably describe you the building. But that's exactly what it is not. A clinic is a service. A clinic is a place where people go to be healed, to be treated, to be helped. And way too often, we describe clinics and primary healthcare centers and even bigger hospitals as infrastructure, as buildings. And we know, and I also know from my own travels to Delta State and to other states, that people can show you different buildings that are unfortunately not being used. They were built as healthcare centers, but then there was no money for the rest to pay the staff, or there was no money for the equipment, there was no money for the electricity, there was no money for the water. So a healthcare center is not just a building. It's a service that combines the infrastructure, obviously, but also the people and the technology that are there. Now, it's good that we have come to realize that private sector can come to the aid. There's not one magic solution to this. It's not like if government does everything, it doesn't work, or if private sector does everything, it suddenly starts to work. No, definitely not. Of course, we can also come up with examples of where private sector clinics are not working. So the beauty of this development in Delta State is that it was joint between the government and the private sector and public and the medical credit fund and farm access and the health insurance agencies. So I think we have come to a beautiful result. And the Netherlands is, as I said, very proud to be associated with this. These were the reasons why the medical credit fund was established. And I will also report back to my headquarters on the findings of the evaluation. But I think altogether we can be very proud of what has been achieved. Thank you very much.
Good morning, everyone. I hope you can all hear me. My video doesn't work, unfortunately. But good to be here with you, though online, celebrating this very important event. My name is Arjan Poels. I'm the Managing Director of the Medical Credit Fund, part of the PharmAccess Group. As you may know, the Medical Credit Fund invests in private healthcare facilities in Africa. We provided over 2,000 loans to over 2,000 health MSMEs of total value of over $150 million in 6 African countries. So the normal business we do is smaller clinics, often in rural areas, sometimes also larger hospitals. But what we haven't done before was a public-private partnership. And that's really something completely different and much more complex, much more players, stakeholders that operate. And as country director in Nigeria, Njide said earlier today, it has not always been that easy, but perseverance is important in difficult matters. And I think together with all partners involved, we've shown that something can be achieved beyond what we thought was reasonably possible in the beginning. I think it has been an excellent model, upgrading, operationalizing abandoned primary healthcare centers that can now cater for patients in their communities that have had to do without for often years, which is really unacceptable. I believe this model deserves to be copied in other states and countries to the benefit of the wider public. And as PharmAccess and Medical Credit Fund, we are there to continue operating and working together with other institutions, public and private, to make sure this actually happens. Because a wider goal in life is to increase and improve healthcare systems throughout Africa. As MCF and PharmAccess, we are proud to have been part of this. MCF will continue developing innovative financing solutions beyond the public-private partnership models. And we are aiming to launch digital loans in Nigeria in the not too distant future, which will also allow for further increase of funding to healthcare enterprises, and also combine these loans with technical assistance. Because as we often say, the loan is just a means to an end. It's never about the loan, but sometimes it's necessary to buy equipment, to finance construction. And that's the same we found in this public-private partnership. So if a loan can actually make this happen, together with the support that the wider organizations can deliver, I think together we can move really far. Thank you very much.
Good morning. Please permit me to also stand on existing protocol. I'd like to say a very big and very warm congratulations to the Delta State Contributory Health Commission and more importantly, to Delta State itself for this very laudable achievement. It stands on its own and it stands apart, what you have done. And I'd like to say a very big congratulations. I'm very honored. Thank you. I'm very honored to be able to stand here participated and actually played a part in this scheme. Our role was quite simple. We represent the private health sector in Nigeria. And what we did was to bring together some of our members to come to join this scheme. Our members, I don't know if I can be permitted to ask them to stand. Please, can I ask our private operators, Dr. Onya, Dr. Itunu, Dr. Eze, could you all please, all of the providers, could you please stand? They took a chance. They risked it all. They didn't just come in. They also had a lot of skin in the game. They were investors in this scheme as well. So they took a chance and brought that quality healthcare to Delta State. And I know we'll be hearing much more about it from our very own Dr. Ben Nkechika when he'll be speaking about it. So without much ado, I just want to say that we at the Healthcare Federation of Nigeria are very much committed to working towards providing Nigerians with the universal health coverage. We're working towards providing the health sector with what it needs to move forward. We're very happy that the Delta State recognizes the private health sector and recognizes what it is that we are doing in the country. And we appreciate you for doing this. We continue to work with all of the others. We also work very closely with Farm Access, and we will continue to work with others, and we are very willing to work with any other states who are ready to go forward and actually emulate this wonderful example. I wish us all a very, very fruitful deliberations, and congratulations once more. Thank you.
Thank you, Dr. Pamela. So I think I'm also going to recognize, if Dr. Faisal Shaibu, the Director General of our Primary Healthcare Development Agency, if he's in the house or any representative. Okay, so I think we'll move forward with the program to invite the man of the moment, the eagle himself, who has. Okay, before the eagle, you take time to really introduce him. So just permit me to first get the grassroots, people who are actually in the communities in Delta State, people who has experienced this program, and also a host of the access to finance facility in Delta State. Honorable Toye Tayed, who is the chairman of Warri South West Local Government. He's a host to the access to finance facility. So to give us goodwill message, we'll wrap it up before we get Dr. Ben to give us his key notes.
Good morning, ladies and gentlemen. His Excellency, the Governor of Delta State, ably represented by Secretary to State Government, the working SSG, Chief Patrick Uka. Let me stand on already established protocol. First, when we came in 2018, as the chairman of Warri Southwest Local Government, my brother, Dr. Ben Keshika, I really, really applaud him for a job well done. When it came to me that it was directed by His Excellency, the Governor of Delta State, that he should come and work with me. You all know that in Delta State, we are in a really deep situation when the governor came in 2015. But by the special grace of God, the governor have the good heart to deliver healthcare to the people of Delta State. most especially in the remote area, rural communities, which we find very, very difficult in our terrain to access. But because of his passion that he have for healthcare to deliver to his people, he was able to set up the contributory healthcare insurance agency, which was being piloted by the Director General. When we came, I told him it's a very difficult terrain, but by the grace of God, we will be able to achieve it because of the governor, who is very, very passionate in health delivery. Came, went into our terrain, which is almost 95% riverine. It's not easy to access, but God giving us strength, we are able to go and deliver it to our people in the community. Today, I can beat my chest, and I'm very, very proud of the governor, who is also the vice presidential candidate by the special grace of God. He has really done marvelously well for our people in Delta State, because it's not easy to go into the riverine, deliver those healthcare. But today, our people are enjoying it through the farm access to our people in the communities. That's today they can really get good health even without spending anything in our communities. So I will really, really give thanks to God that by the special grace of God is going to do more and to rescue Nigeria if given the opportunity to do it. Thank you and God bless.
Thank you very much. I think we've heard so much from goodwill messages from different spheres of what is happening in Delta State and continues to happen. I must say, I don't know how many of you have been into the creeks, but if you manage to go there, you understand and have the bigger picture. Permit me to stand on existing protocol. At this junction, we would like to hear from the Delta State Contributory Health Commission, the DG, who incidentally is the principal and the bundle of energy to making this a success. Let me invite Dr. Ben and Kechika to the podium. Thank you.
Good morning, ladies and gentlemen. All protocols observed. I will try to make this very brief because we have the question and answer session. So we'll try to be very specific at that point. I have a slide presentation. There is a short video, and then we can have further discussions. Thank you. Yes, we are here today for the Asset Finance Program Impact Study Report Dissemination. But there's a story, a journey, and an outcome that has brought us all here today. In early 2016, at an advocacy event with traditional rulers in Delta State, an elderly king, His Royal Majesty G.O.E. Temo Bini Peretri, the Agadagba of Ebema Kingdom, called me out and said that the way I'm speaking, it looks like I'm serious of what I'm saying. And I was very surprised. And I said, Your Majesty, why do you say so? He said, there's a hospital in my kingdom that was built by a multinational, and for the past 25 years, it's been locked up. And we've been asking them to please, how does it start? And nobody has ever responded to him. And he's about 90 years old. And his desire is that that facility provide care before he joins his ancestors. So I say, Your Highness, I will get it done. And I paid him a visit with my team. That's it. And I said I was ready to go. And this was at about 11 o'clock in the afternoon. I said, it's like you don't know where you're going to. I said, why? He said, the boat is waiting for me. He has some able-bodied men to go with me. And there's actually a 4-hour boat ride going and coming. And that before I embark on that journey, I have to have to watch the tide or else I won't come back on that day. But interesting that before then, I already spoke to the governor and he just said, go and see Honorable Tai. And I spoke to him and I said, there's this situation. He said, Ben, whenever you are ready to go, tell me you are fully covered. So with that confidence, the next morning, we embarked on a journey. Slide 3, please. And when we're going, we called it the Mission Impossible. That's the ambulance. This is my team. That's Dr. Eze with me and Dr. Lamide. And that's our able boat captain. I had to go with security. My friend, the Honorable Commissioner for Information, gave me a media crew to go with me. That's what's in the boat. That's your Prosa healthcare facility. There's Polobubo and Sekeleu. This one we arrived. These are the able-bodied men that went with me. Now I know what able-bodied men mean. And I had to call to say I'd arrived. And this is the team. Those are nurses that joined me from, they came in from the United States. They said they needed to go with us. And that's His Majesty. He made all this possible. Without him, I wouldn't have had the courage to go. And that was the day we did the opening. He's an old man, but on that day, he decided to travel 4 hours also to his community to witness that event. That's the king of Oporosa, and I'm sure you know where Oporosa is, where we have our former warlord, Tompolo. I met 7 checkpoints in that community, but they allowed me go in. But they all supported me. And he received us warmly and gave me an assurance that anytime I want to come to that community, I should come in and nobody will ever disturb me. And that's when we're walking to the facility for the opening. That's the representative of the governor at that event, the chief of staff at that time. These are the community leaders. And that's the president general of the community. And we had Chevron come join us on that day. And that's Honorable Tai with me there. He also came. And that was how I've been told how to greet His Majesty. I had to learn. That's the king of Obio, Chief Benjamin Delue is here with us. He was the first person that said all the medical doctors and nurses that will come to his community will live in his house. So they all started from his house. That's Ode Shekiri Healthcare Facility. That's Alioku. Alioku Healthcare Facility is peculiar. It was donated on behalf of the Chief of General Defense Staff, and it wasn't operational. And he called me, he's my friend. He said, Ben, make sure that facility works and is functional today. Please continue. Now the impossible became possible. Services was now being rendered in the faraway riverine communities. So it was no more an impossible journey. It's now a possible event. Immediately after this, I will select some pictures and give you some stories behind some of the pictures, but this is just a video presentation. All this you're seeing is healthcare services, 3-4 hours deep in the creeks. Yeah. One of the deliveries in those communities that didn't used to happen before. Major surgeries, a hysterectomy was done in the creeks by a team of doctors. That boy is smiling and happy. Look at his face. And the beauty of this is that all this have been possible because of the pressure, the input, and the encouragement from Farm Access Foundation. When they first brought this program to me, I was a bit skeptical because it was difficult interacting with the private sector, despite the fact that I was from the private sector. But when you're on the government side, it's not always easy. Njide knows how much we battled until we decided. That's the field team of the Delta State Contributory Health Commission and an award. And now the impossible is now possible. Thank you. Next slide, please. We're going to hear some very interesting stories that depict the outcome of this situation. While they're trying to bring up the pictures, I will tell the story. I've told the story of His Royal Majesty, TMO. I'm happy that this event has come up to talk about the outcome, but I'm also emotional that he's not here today. He passed on a few years ago, but he fulfilled his dream of having that facility functional while he was alive. Next slide, please. When we got in there the first day, we saw a lot of women with their children. You could see from the photographs. And we told them, come to this facility, antenatal is free, delivery is free, service is free for pregnant women and all the children under 5. But when we started checking, when it was time for delivery, we couldn't find these women. And we started searching for them. Nobody could give us any information. So one day, with support of my friend, I went with a team and I went into the community. I organized a football match with the children. And while the football match was going on, we started going into the homes. So the football match was a distraction, but we started going into the homes to ask, where are the women having their delivery? And they said there is this spiritual healer who had created a taboo impression that if a woman is delivering and any external person sees that woman delivering, and that person is a bad person, the person's evil spirit will take over the child. So because of that, for any delivery to take place, the only person that is present is that spiritual healer. She's uneducated. In fact, I don't even know that is a she or a he, because I didn't want to ask. But obviously uneducated, and that means that whoever woman that comes out there alive is the only one that delivered safely, or a child that comes out there. So nobody could even account for what was the mortality or morbidity in that environment. I tried to intervene, and I was told, don't even attempt, that this person is referenced. So I sat with my team, and I said, okay, we have a way to go about it. So we recruited an elderly matron, who we now claim was also a spiritualist. So we set up a room in our clinic and told women that we also have that capacity. And then we started looking for a prime patient whose relation wanted to call to worry to deliver. But the question was, how will she travel on the boat 4 hours with that kind of pregnancy? And she came in and we managed her with the woman, but the doctor was going through the back door to go and check. And she had a successful delivery and everybody was happy. Next slide, please. Please just stick to the slides. Thank you. No, go back, please. Good. Those are the ladies. This is the first delivery in Oporoza and the first delivery in Prolobubo Hospital. And when that story went out, a lot of women were now encouraged to come. We now face problem 2. One of these children was a male child. So we did circumcision. And in 3-4 days, the wound healed. And the story went around the community that, you cannot circumcision, the child doesn't die. And I said, why? They said, most of the children that came out of that spiritual home alive now ended up with neonatal sepsis. So majority of them were dying off. So the women now deliver successfully, but they don't circumcise the children. So they bring them out, and you are now seeing grown-up young boys in that community uncircumcised. But because of this successful process, families now started bringing their children to us for circumcision. So we had 3 days a week that were doing circumcision, and some of them 15-year-old boys were coming. And that's a photo session. So for each time they come, you can see the husband, the children, they are happy that that circumcision has taken place. So gradually, we started building confidence, and that has helped outcomes. Next slide, please. Now, I remember I said when I went to Oporosa, I met 7 checkpoints. Luckily for me, once I disembarked from the boat, I met a man. He said he was a catechist in the community. So I told him what I was there to do, that I heard there's a facility in this place and that I've come to see it. So he followed me through all the checkpoints. At each checkpoint, he talks to them to let me pass. And then the last one, this one said, nothing will make me pass this place, that I must go back. I pleaded, and he made a statement. He said, we've been begging people to come and start this facility. He was talking to them. Over 25 years, this young man has come here. You want him to go back just because you want to show you're strong? If this man goes back, anything happens to us, we'll hold you responsible. And that made sense. And they said, okay, they will take me to the place, but I must leave my security escorts behind. I said, no problem. And I said, where is the hospital? And they pointed into a forest. And I said, where is it? They said, it's in that forest. So I said, okay, they brought bulldozers and co and cleared the place. And behold, there was a facility, big, and the equipments were all inside intact. All we did was bring in a medical technologist who checked it. And the next question is, how do we bring people to work in this kind of environment? And while we're discussing, I looked across and I saw a flare, which meant there was a flow station in that location. And I said, I'm sure in that location, there are doctors, there are nurses, and clinic attendants that come to treat the oil and gas workers. If those people can go there, they can also come here. And the model is this. Those people run shifts. When they come to the location, their laundry, their catering, everything is taken care of. They provide DSTV for them and all the comfort. So we should be able to do that. So we contacted Toronto Hospital, who had a team of doctors, nurses, and we said, let's develop this model. So the model we basically used was, every facility has 2 sets of people, 2 weeks in, 2 weeks out. Once they are there, all they concentrate on is providing care. We brought in generators, we brought in solar, and the doctors were willing and happy to do that. That is actually the model we're used to ensure that providers are able to go to those facilities to provide care, and the people are able to walk into those facilities and receive care. Next slide, please. So while we're doing that, that catechist kept coming to the hospital to make sure everything was fine. And once in a while, he'll come and say, I have body pain and all that. And I told the doctor, I said, these people that haven't even seen a doctor for 20 years, let's do a full medical for all of them, just to know what other conditions they had. And behold, the man had a massive inguinal hernia. And we said, you keep coming here every day and talking about body pain. Why haven't you showed us that? He said, that one that they've told him is 75,000 naira for the surgery in Warri, that he has saved 40,000 naira. So he's waiting for when the money is complete so that he can travel to Warri to provide this, receive the care. And we said, no, it's possible in this hospital. He said, so that can we accept the 40,000 and do it? We said, no, it's free. He said, it's not possible. But here, please don't move the slides until I tell you. Thank you. Go back, please. Good. And we had a hernia done, and he was happy. He had his 40,000, and that message went around that what they do in Warri is possible in Oporosa. And guess what? People travel from Warri to Oporosa to do surgeries now. Next slide, please. Yeah. So one day I got a call that there's a lady in the clinic and she was very pale. And the diagnosis was a ruptured ectopic pregnancy. And how do you manage a ruptured ectopic pregnancy deep in the creeks? And I said, there's only one way out. The gynecologist would depart with a team with blood straight to the location. The doctors there were to just keep the woman holding on till they arrived there. And we did a laparoscopy, and the bleeding was stopped, and the woman was fine. That's a photograph. And because that story was going on, one day a woman walked in, and she said she was 7 years pregnant. And we said, why? She said that they told her she has a demon in her stomach, and that she doesn't know the day she will deliver the demon. So she's holding up because she knows the day she delivers the demon, she will die. So we said, okay, we know how to deliver demons. So I told them to bring an ultrasound scan. And you know how it is when you're playing around with the scan, you'll be seeing things. And we told her, can you see the demon moving around? That at the way this demon is moving, the demon cannot come out normally. So we'll have to cut you and bring it out like we did the other women. And she signed the consent, and we brought out a massive fibroid. It was so bad that the solution was a total hysterectomy. But these are the few success stories and more we've had. Next slide, please. To be continued. Thank you.
Please, can we give me a round of applause again? So I will say that picture is not complete. I think you missed out one of your team members, but we'll talk about that later. So yeah, very touching. Next on the line, we've heard how this has happened. So as Farmers Foundation and the Commission, it's also important to look at things that we try to do. How well did we go? What we didn't do so well, and how to improve upon it. And as such, we asked, we looked at getting someone who is independent, someone who can be able to look at everything unbiased and give us a picture of how best we are performing. And so he may be small, but he's mighty. I would like to invite Mr. Sunday Bejume, who was the consultant to look at this program and highlight key success factor and areas of improvement. Thank you. Sunday, please welcome. Please a round of applause for him too.
Good morning, distinguished ladies and gentlemen. My name is Sunday Bejume, the independent consultant working with Farm Access on this very laudable initiative. Before proceeding with my presentation, I would like to stand on existing protocol. Thank you very much for your time. Can we have the slides on the screen, please? All right. So it's a very big pleasure to be in your presence here. Yes, we understand in the healthcare space in Nigeria, the primary healthcare system happens to be the bedrock of care and ensuring that people live well to be able to achieve whatever productive aim that they seek to achieve. But you will also agree with me that majority of the not so nice indices that we've been reading about in terms of healthcare in Nigeria is as a result of very fundamental challenges that we seem to be grappling with, particularly at the primary healthcare level. So it is with a very great delight when I was called upon to work with the Farm Access team to look into this very initiative and to assess how impactful it has been. And I'm very happy that many stakeholders here and those watching us online seems to be gaining that momentum of hope that truly there's actually a way out of the challenging situation at that very level. So thank you very much once again for the sponsors of these ideas. And it is my prayer that there will be more grease to your elbow as you move along. Thank you. All right, please, next slide, please. So these are the very brief highlights that I'll be touching on very briefly. I'm very sure sooner or later you'll be given copies of the report for you to have some extensive review of it. So we start on with the baseline situation of PhDs in Nigeria. Next slide, please. Okay, so at the beginning, I heard Dr. Olumide talk about certain archetypes. And I was very happy he was able to touch on some of these very critical elements when it comes to assessing PhDs and the way forward. Next slide, please. Next slide. All right, so currently, based on data from the Federal Ministry of Health, primary healthcare centers constitute about 85% of total health facility in Nigeria. And that translates to over 34,000, as you can see on the screen. That's as at 2019. So it tells us that if 85% of health facility in Nigeria are based within the primary healthcare system, it tells us how very vital the primary healthcare centers are to the Nigerian healthcare sector. And I'm particularly happy that key policymakers that have the interests of this layer of healthcare in Nigeria are here present. I also want to particularly thank the representative of the ministers of state and the core minister of health, and also His Excellency, the Senate Chair on Healthcare, Dr. Olori Egbe. I'm a very keen follower of you. I follow your proceedings on NTA, so I'm very delighted that you're here present. There are some worrisome data that we spotted. Maybe the course of the QA, you could provide some insight, for us. One of them is the fact that there is this report that we have that about 20% of the PhDs we have in the country are functional at the moment. So that's a huge gap, but that is also one of the motivations for us to ensure that this access to finance program, together with other variants that others may be thinking about, is actually something very, very important for policymakers to look at deeply and see how we could make sense out of it. And what is the impact of this, rather disturbing data on the screen? The International Center for Investigative Reporting, as of 2016, provided the figures you see on the screen. 2,300 children under the age of 5, 145 women of childbearing age, reportedly pass on a daily basis in the country. Very, very disturbing. But we are very happy that we are beginning to look at the need to embrace PPP intervention as a way out of this situation as we have. Next slide, please. Okay. All right, so yeah, so some of the speakers had earlier spoken to the framework of the access to finance, but we also conducted, a review in the course of the evaluation exercise, which we are going to see very shortly. Next slide, please. So this is how the government end is handshaking the private sector end, and also how the financial institution is also coming in to play a role, and what MCF is also doing in the whole arrangement. So I'll just quickly run us through what we have on the screen. So to the left of your screen, you see where we have the funding bodies handshaking each other. We have the government through the Delta State Contributory Health Commission and the Bank of Industry providing funding, which is described as a commingled funds on the screen, to be able to allow the private healthcare providers who have indicated interest to play in this space to access debt capital. Now, the private healthcare providers could have gone in on their own with their own funding. But of course, coming to rural areas and the creeks, like Dr. Ben had earlier described, to a private healthcare player in Lagos, for example, in Anambra or Abuja, you will need to do much more to convince, such a practitioner to relocate from the city, down to, those difficult to reach and, should I say, quote and unquote, rather unattractive areas. So the government, in its wisdom, thought it wise to provide certain ingredients for motivation to attract the attention of these players to support the government on this initiative. And that is what led to this funding arrangement between the government and the Bank of Industry. Another important thing that was done here, there, is the fact that the funding is coming at a rate that is way below the going rate that you will get from a typical money deposit bank. Single digits, okay? Which is very, very attractive, very, very rare even for the practitioner to access on their own in the city. So they provided that commingled fund. It is important to also mention that these commingled funds have been guaranteed by the Medical Credit Fund and also by the commission itself. That's the Delta State Contributory Health Commission. So why do we need that guarantee? It is important because we could have instances, it's a form of risk management, essentially. Instances where you've made projections that, okay, we're going to get X number of allocated patients, and then by the time we get the payment in terms of claims and capitation, we should be able to, take care of this debt facility. And then something happened, the projection, nosedive, sort of. But there's a guarantee to ensure that the funders don't lose their money. So fantastic idea, well thought out, and I really personally would like to appreciate the initiators of this whole idea. So now you could see that the MCF is there. They provide a partial guarantee together with the commission, and then the private healthcare players are able to access this debt capital. So you can see that accessing that debt capital also takes away the strain, in their own private purse. You can see that. So they're able to access the capital, they render the service to people, and then when they do that, the commission also pays the relevant claims and capital that ought to be paid. And then they are able to, service the loan that was accessed. Now, I need to mention this very important point here, which of course, as an independent person, I also got to find out in the course of conducting the evaluation. Now, if this program had not come to play in the first instance, the government would have had to go source for extra funding elsewhere to revitalize this moribund facility. And recall, in the public sector hospitals or health facilities are more or less cost centers, basically, aside the social investment return they get. But financially speaking, they are cost centers. So government is actually bleeding out. Money is going out, but money is not coming back from there because government is not for what? It's not for profit. And we all know fiscal challenges that government across various levels of the economy is confronted with as we speak. So if we have a setting where, yes, the government is providing seed funding for the purpose of attracting private players, but at the end of the day, the government is able to recoup that seed funding, and possibly maybe with little or no margin, but at least the principal seed funding has been what? Has been recouped. So essentially, the arrangement is a net cost-saving measure for government. at the end of the day. Please, I would like us to give a round of applause to Delta State government and Farm Access for this very fantastic, idea. Please put the slides on, please. Then there's also one more thing that Farm Access also provided in this whole arrangement. And the country director mentioned it earlier in her brief speech a while ago. And that is talking about quality. Okay, we've looked at access to funds, revitalizing the facilities, providing services. How do we also ensure that the services being accessed in these rural areas and difficult to reach regions of Delta State still radiates the kind of quality standard you will get elsewhere? And that is where Farm Access Safe Care team comes in. So from time to time, they provide assessment, checking the quality of care provided at this facility to ensure that they don't fall below a certain minimum threshold. And that is extremely vital for program success. So Farm Access, thank you very much for that. Next slide, please. So I've said quite a lot already, but in summary, we have just a snapshot on the screen. So the Access to Finance program is a joint initiative that was put together by Farm Access and the Delta State Contributory Health Commission. So it runs on an FOT PPP model, which is finance, operate, and then transfer. So in other words, government still remains the substantive owners of this facility, while our private partners are helping us to operate it. And of course, some level of funding will also have to come in for them to operate. Then after the specific timeline that have been agreed lapses, automatically ownership, reverts fully back to government. But of course, there's a window of extending it further depending on the context that we have on ground. So in all, there are about 15 health facilities that have been taken up. And of course, it's more like a pilot of some sort because it's a learning phase, as it were, and it's undergoing some various levels of perfection as we speak. And then we have members of the HFN. I want to thank the HFN for also opening their doors to embrace this initiative. We have 6 private operators from that trade block helping to drive the reactivation of these moribund facilities. Thank you. Next slide, please. So what value are we proposing? What exactly do we seek to accomplish, out of all this? And that's what we have on the screen. So like the country director said earlier, if you enroll so much and there is no access point for people to, access quality care, the whole effort is not complete. So the whole essence is to provide quality care for people in these difficult to reach areas of the state through the revamping of the dysfunctional or moribund primary healthcare facilities. And of course, like I also illustrated earlier, it also serves as a way of lessening the fiscal strain on government. Honestly, I'm very sure His Excellency, the SSG, will definitely appreciate this. Currently, budget is very choked, as we speak. But if there's a measure that could help lighten that fiscal strain and also enable government to still be able to cater to the healthcare needs of its people, they will definitely throw their door open. So that is one of the major value proposition of this program. Then, of course, there's another proposition that is also coming with this, which I didn't include on the slide. And one of them is to ensure that, of course, not on the short term, but on a medium to long term basis, our private partners should also be able to, reap certain returns for their investments. But of course, it's not going to come on a short term. But if we have a medium to long term disposition, definitely that value will also be earned. Next slide, please. All right. So, Doctor has pretty much, dealt with the genesis and the storyline behind the images on the screen. Next slide, please. So what are the key benefits? Of course, we've been talking about it all along, but we'll just x-ray it very briefly. Next slide. All right, so the impact. Next slide. So higher return. So this is what we did in the course of conducting the impact evaluation. Now, what we did was to calibrate the stakeholders of this initiative clearly. We have the government, we have the commission, we have the people, we have the private healthcare operators or players. Every one of these stakeholders have their own interests that needs to be catered to. So when we are discussing impact, it also have to resonate with these blocks that I've mentioned. So for the private players, yes, some of them came in and said, you know what, this pretty much aligns with our CSR initiative. But honestly speaking, from a medium to long-term perspective, we also need to consider their own return on investment as well. All right? For purpose of what? Sustainability. So this program has, let me put it this way, it has demonstrated capacity to provide, return on investment. The issue is that it is not going to come in the immediate term, rather on a medium to long term. Next, please. Now, in Delta State, there's a report that was done by the UNDP. And it was stated that for under 5, the number for under 5 mortality in Delta was put at about 53 per thousand live birth. And then for maternal mortality, it was placed at 188 per 100,000 live birth. So we took note of that as a baseline, should I say as a benchmark for reference. And then we examine what the performance on this particular indicator has been since inception in 2019 up to the end of 2021. For under 5 maternal mortality rates, as far as the access to finance scheme is concerned, we recorded about 6.3 per thousand as against 55 per thousand for the state generally, which is a marked, improvement. But we didn't stop at the historicals. We also did a projection up to 2026. And we are confident that with the progress being made and the perfection of certain rough edges here and there, it is possible to attain 0 mortality rate for children under 5. So we estimated that by the end of 2026, if we draw from 2019 to 2026, we may likely arrive at 0.7 per thousand, which is very, very possible. But in terms of maternal mortality, we had 0 incidents for maternal mortality. Round of applause for access to finance. 0. As against 188 per 100,000 live births, we got 0 since 2019 up to the end of last year. Very fantastic. Next slide, please. All right. And then there's one more thing. Our people now have 24 hours access to care. A round of applause, please. I personally, in the course of conducting this evaluation, I personally visited the nooks and crannies of Delta. I spoke with the rural women themselves. In fact, one of them told me that there was a neighbor of hers that had, an issue around 2 a.m. And they got to hospital, they met a doctor on ground. They met nurses on ground. In fact, one of the requirements that we discovered in the course of the evaluation was that it is mandatory that every facility under the scheme, should I say program now, must have a resident doctor on ground. Very fantastic. And that is one of the things that actually was responsible for the performance we discussed earlier. Next slide, please. Job creation. Job creation. You know, where you have private sector coming in with their investment and the rest of them, definitely they will need people. So cumulatively, between 2019 to 2021, a total of 243 direct jobs have been created for people. We're not even talking about the indirect jobs now. Imagine if we scale from this minute 15 to much sizable number. You can imagine the number of people in this community that will be absorbed in the employment space. Next slide, please. And then, of course, higher investment input per facility. If we are to divide the state government's allocation to primary healthcare, revamping, and the rest of them, by the total number of PHCs in the state, you realize that the number you will get per facility will be very low and cannot even sustain them for a year. But by the time we looked at the total investments made by the private players, and we divided it by the number of facilities they are handling, we discovered that the differential between what this program is bringing to the table and what ordinarily would have achieved on its own. This is very, very laudable. Next slide, please. And then finally, like I mentioned earlier, cost savings to government. You know, government resources is very, very straight. If we examine the fiscal system of public finance in Nigeria today, particularly for it at the subnational level, it is stretched. But when we have a program that lessens that strain and open the door for them to be able to achieve the social goals that they've set out for their people, I think it is worth embracing. All right, so next slide, please. I'm almost done very quickly. So, yeah, so we need to now start speaking to the numbers. This is just like a high level. If you look at the report, some extensive details have been provided. Now, it is important to establish that these facilities, before access to finance intervention, were not functional. I believe you understand the implication of that. They were not what? Functional. 0 patients, 0 recorded within a short period of 3 years. So you will see that in terms of patient growth, in 2019, when I think they started the last quarter of 2019, right? Last quarter of 2019, just a little over 8,000. And by the end of last year, the number is going above 30,000. And then on average, across every facility, 85% of the patients are insured. So in terms of the fact that I don't have money, that is why I cannot access care, that has been completely, taken care of. Then we project, because as at the time we were putting this together, we were looking at 2021 as the cutoff point. But we also did some projection that by the end of 2022, we should be having close to about 38,000 patients toward the end of 2022. And then by the end of 2026, way above 90,000. Of course, we tallied the number of beds across these facilities in the course of our evaluation exercise. And we tallied about 182 beds. And the private players will appreciate the fact that each bed is a revenue center. Am I correct? Each bed is a revenue center. And I'm going to explain what it means. Okay? Some of us are also very familiar with the concept of average length of stay, isn't it? Okay? So you could compare the model with that of a hotel. Okay? So if, for example, we have 2 hospitals, A and B, and hospital A keeps a patient on a bed for maximum 3 days, maximum. Hospital B is doing maximum 6 days, right? What it means is that by the end of 6 days, Hospital A would have earned twice the income of Hospital B. Is that not so? So that is why when we start talking about number of beds and then you add average length of stay, it begins to make certain financial sense to our private players. So that's what we have there. So we went as far as also trying to establish what is the revenue distribution per bed space for the given periods. And that's what you see on the screen. But the conclusion here is that between 2019 to 2021, the revenue per bed space has grown by over 71%, which is very remarkable. Next slide, please. Okay, so when it comes to patient encounter, there are different perspectives to it. There's a much larger perspective. There's also some segmented perspective. But this time we're looking at the outpatient and the inpatient traffic this time around. So for the outpatient encounters or visits, it grew from 11,000 in 2019 to about 67,000 at the end of 2021, which is about over 500% growth rate. So it tells you the extent of the penetration and the traction the program is gaining. Of course, antenatal care ANC, under 5, and other cases accounted for 35%, 64%, and 1% of the OPD numbers earlier discussed. So in terms of admissions, that also grew from 868 cases in 2019 to over 5,000 cases in 2021 at an average annual growth of about 158%. So, you know, and that is not surprising because you see, when you start something afresh, the growth rate tends to be larger at the beginning, particularly for the first 3 years, because the numbers then are still relatively small. Take, for example, if you grow from 1 to 2, that's 100% growth. Is that not so? That is because the numbers we are starting with is relatively small. But as we begin to gain traction, there will be certain steady state that we'll definitely be getting eventually. So that's what we have at the end of the day. So by the time we combine outpatient numbers with the inpatient numbers, we discover that it will gross over 88,000 for this year. That's our estimation. And then about 196,000 by the end of 2026. So those are the expectations that we have for the immediate future. Next slide, please. So I'm almost there. So these are the pictures. You could see overgrown grasses. I'm happy the fact that one of the operators who helped in revitalizing this facility is also here. You could see that was how, to the left of your screen, that was the situation. But to the right, even when I got there, I could not believe I was in the village, honestly. You know, the access, the entry route to the facility alone is very, I went in there, met with everybody, checked everywhere. You know, we have so many pictures that we took there, but this is very, you could also see the generating set as well. So power is really not an issue. Next slide, please. So this is for another one, Ovade. For the Ovade facility was actually established by one of the oil multinationals. I think it was a JV arrangement or so. But you could see what the state was before the intervention and where it is at the moment. Now, I need to also mention something very important before I move to the next slide. And that is the fact that aside providing access to finance to drive the motivation of the private players participating, there was also something I noticed in the course of my work, which the commission did. And I'm very happy the DG is here as well. They went as far as also tackling the issue of energy, power. So they were looking at off-grid energy solution. And this is very, very, for facilities in rural areas. You know, talking about immunization of children, you cannot keep these vaccines, you know, at anyhow temperature. Am I correct? So there is need to have arrangement that ensures that when these vaccines are brought to these facilities, they are kept at the appropriate temperature for ease of delivery to children and women. And that is where the concept of this off-grid energy solution thing came up. And you could see on most of the facilities I visited, they have these solar panels on their rooftop, you know, and these solar powered deep freezers as well that could preserve the vaccines at the right temperature for the people. Very commendable as well. And of course, in the course of the study, we did an extensive analysis of the energy consumption of each facility, which of course you will see in the documents. Let's move on, please. Next slide. So what are the lessons that we could take away from the experience at Delta State? So now I need to mention this. It is not a 100% perfect initiative, as it were, because 3 years is too short a time to perfect a system of a lifetime. But they've done remarkably well from my assessment. So what are the few things we could take away from Delta State? Next slide, please. I should be closing up here. So yes, and this is just for those of us who may be interested in adopting this initiative. Now, one of the things we will advise is for us to ensure that a proper feasibility study is conducted. Now, this is very important because it helps us to really identify with empirical data what the specific needs of our state or our people in the rural areas would be. Because the situation in Delta will definitely be different from the context you will find in other states in Nigeria. So whatever solution or adaptation we seek to eventually evolve, it must be contextual, but to ensure that we don't get it wrong at the design phase, we must do a proper feasibility study. It will help to identify what the possible risk would be, what mitigations can we put on board, and what are the expectations, for the program. The next one is stakeholders and the roles they play. You could see what Dr. Ben, displayed, when he was making his own presentation. Community participation and ownership is vital for success for a program, like this. And we recommend that it is fit for purpose for adoption within the context of your state. Next slide, please. And then, of course, we need to optimize our operating model for the program. And what do we mean? Very importantly, we need to have a very strong and functional M&E system. We've recommended that for Delta, and they are looking at it as we speak. And then, of course, there are certain policy documents already put forward by the Federal Ministry of Health. And of course, there are some other models that we also recommended in the course of the evaluation. Next slide, please. And then we need to ensure fiscal sustainability, because government is actually driving this for private sectors to come and participate with them, to handshake government. But the truth of the matter is that we also don't want a situation whereby government has so much financial burden coming from this kind of program to knock them down. That could also water down their commitment, going forward. So we need to ensure, can you go back to that previous slide, please? So we need to ensure that we are able to manage that. And then, of course, if you look at the last bullet point there, we are also trying to use this opportunity to encourage high net worth individuals to also go out of their way to support government in adopting some of these PHCs around. That could also help in terms of providing alternative financing, for reviving these health facilities. Next slide, please. So once again, what are the critical success factors? Next slide. So number one, there is need for a strong political will and ownership by whether state government or the federal government. There is need for a strong political will. Now, next to that is that we must have a strong, viral, and functional health insurance scheme. Because you see, the health insurance arrangement, like what the commission is doing in Delta, they are the ones that brings the demand side to the providers. So if somebody decides to go to the rural areas, revive a facility, set up everything, and there is no patient traffic, that's the end of that whole exercise, right? So the health insurance is there to mobilize the demand side and then bring them to the doorsteps of the providers. And then when services have been rendered, it is up to the health insurance agency to ensure that the payment due to the providers are made available as and when due. Because money in and of itself is what oils the engine of the private players. Okay, so the third one is the quality system, which of course we have mentioned earlier on, and then technology. Because, we mentioned M&E the other time. There must be strong, robust technology on ground to allow for ease of tracking and evaluating success. So we don't need to wait until after 3 years before we start assessing how we are doing. But if we have technology in place that provides real-time assessment of what is going on, intervention can be provided in a timely fashion to address any risk driver that must have been identified. So that is also very important. So on that note, I would like to say a very big thank you for taking your time to listen to me. Thank you and God bless.
Sunday deserves more hands, because this is such a very, very laudable news, seeing people or women that can't access healthcare. People that facilities are overgrown, and suddenly these facilities look like the facilities you see in the city centers, functioning and giving people access to quality and affordable healthcare. So I can say this is a laudable initiative. So please also permit us, we want to collapse everything so we can just get this done and dusted. So we'll be holding on the tea break so we can move directly to the next activity.
Proceed. We have some colleagues who joined us online that we also want to recognize. Please, we want to recognize the DG for the Kwara State Hospital Management Board, Dr. Sahad. He's online and he has joined us. Thank you, Dr. Sahad, for joining us. Oh, he's here physically. Okay. Thank you, Dr. Sahad. We also want to recognize the wonderful people, providers who has also, important people who have ensured that this facility are up and running, providing quality healthcare, exactly the same quality they are providing in the city, ensuring that people in the remote areas are having access to this affordable healthcare. Permit me to recognize Dr. Ngozi Onya, who is the founder, CEO of the Pelon Memorial Hospital. She's here with us today, and she's one of the providers for this scheme. Also recognize the Society for Family Health. They are also one of the providers, Dr. Omokundu Igodo. He's also the one of the providers on this program. Also permit me to recognize Dr. Emeka Eze, who is the CEO of Toronto Hospital. Dr. Itsunu Akinware, CEO, Medbury Medical Services, and Dr. Lucky Obara, who is also the Capitol Hill, MD for Capitol Hill Hospital. And also, not least, Dr. Efumbo Dosekun, who is also the CEO and founder of the Outreach Hospital. These are wonderful providers who, are ensuring that access to finance and quality healthcare get to the wonderful people of Delta State, and we say thank you for the awesome and marvelous work that you have done. We move straight to the moderation. Now we want to share success stories from people who has either experienced these services, either as a provider, regulator, also patient. So we want to hear from hands, their experiences. And from this conversation, we also get to hear lessons learned, experiences, and know what can be done better and what also can be adapted. Hearing directly from people who have experienced this program. Please permit me to invite Dr. Nelson, who is at the community base and supporting this wonderful work to come to the moderation seat. Also permit me to welcome Honorable Dunye Taye, who is the chairman, Warri Southwest Local Government, a host of the Access to Finance facility. He also is going to be sharing the experience of having this facility and in his place. Please have a seat, just choose anywhere. I also invite Chief Louis Benjamin, the former Deputy Governor of Delta State. He also a host of the OBO Healthcare Facility to also join us too at the stage. Doctor, maybe he stepped out. Okay, he's coming. Please, let's clap for these people. Let's encourage them as they walk to the stage. Also, I'm inviting Dr. Ben Kechika, who is DG of the Delta State Health Contributory Commission. He's also going to be giving us his own side in terms of regulating and managing this laudable program and initiative. And also, I'm going to also be inviting Dr. Wala, who is also a medical doctor who works closely at the facility. And of course, he will share perspective, of interacting and providing services and care, to the users of this healthcare facility. Hands of applause for him. And finally, I'm going to be inviting Ozo Osisiogo, who is one of the key guys. He's our Director of Medical Credit Fund, Pharmacist Nigeria, and he has, of course, been there from the inception of this program, playing key role to ensure that the success you're seeing today, he's one of those people that have contributed immensely to it. So, please, he's going to moderate this conversation today, to hear from the side of the people who has experienced it either as a regulator, user, and provider. So we are going to move this. So, listen.
All right. Thank you for having us up to this time. I know time is fast spent, but this is also a very important session of this program. We would like to, since morning we've heard from different individuals concerning this access to finance program, but I think it's important that we hear from the field exactly how the community, the regulators, providers, even patients, as like, how this program has impacted and what will be their, experiences, recommendation, and the way forward in driving a journey towards universal health coverage. But also, okay, so for the sake of if I stand on all existing protocols and the power vested upon me, I would like to invite Dr. Oke. Is Dr. Oke there? Yeah, Dr. Okay, please, because I think we've heard from Dr. Ben so much today. So let's give her a round of applause. I think someone else needs to come from the commission. So let me start from Honorable Toyotai. You're the chairman. You're the host, I guess, the chairman of Warri South, Southwest local government, so host community. Basically, I would just like you to share your experience based on where your community has been up till when the Access to Finance program started. What has been the community experience? You can switch off the mic when you want to talk, then you switch it on. Thank you.
Okay.
That's okay. Please proceed.
Yeah, the communities and the local government have been in a very bad situation. The inception. Oh, it's not okay. It's not okay. Yeah, the communities in my local government have been in a very bad situation. And some years back, but since the inception of the contributory health insurance scheme and the access to finance, also with the private partner, public partnership, it has been a very great improvement in our various communities. For them to access the healthcare has been very, very challenging and difficult to our people. But for now, some years back now to date, we have really enjoyed the health facility in our various communities in the local government, from the state and from the access to finance. So I will also advise other states that have not been able to key in, try and key in, because so it's been really, really helpful for my people and the communities and the local government at large and in the other states. Because most of these communities, they find it difficult to access health facilities. But since the inception of this contributory health insurance scheme, which has been piloted by Dr. Ben Ikeshika, it has been really, really helpful and impacted in our communities, in the local government and the state at large. So my advice for other states that are not keying in, you try and key in, because the access to finance can be really, really helpful for our various community and the local government. Thank you.
So let me come to Chief Elue Benjamin. Good morning, sir. You're the host for the OBO Healthcare Facility, I presume. And of course, as an elder statesman, you probably have seen different aspects of health, health emergencies and issues residing in your community. What has been your experience since the OBO Healthcare Facility was revitalized? Can you give us our attestate to your experience, sir?
Yes. Okay. Good afternoon, ladies and gentlemen. Thank God we are witnessing a system that is going to revolutionize our healthcare and health delivery system. My community, Obio, in Anyocha local government area of Delta State, is the first or foremost beneficiary of this innovation in healthcare delivery. I remember as we were stepping out of office, my community was one of those to be built and equipped with hospital, we called it that. But how many years down the line, it was not completed by successive governments until 2015. I went to my Oga, the governor, present governor, who himself as a medical, political governor, decided to revitalize what people used in my community and the environment to say that I was not able to achieve before I left office. Say, please, this is a stain on my body. How do you revitalize this thing? It's all very bound. I said, you said, you know what? There's this idea of primary health care. I want to use your Obio community as a showcase of what they wanted to do. And I thought it was a joke. But the confusion was it going to be hospital or primary health care or health center? Nomenclature, the name caused confusion for a very long time around that place. That I have connived with governments to privatize our hospital. They call it, they politicize it to the extent that I nearly lost my integrity and my standing in the community, that I have sold out the idea of having a general hospital in my community to private sector. We couldn't understand it. So many years gone by. We try to say that this health is the same thing, provided you are well. There is, most politicians around refused. But thank God today, since 2018 to 19, a new story is around that Obio is a mini health center for the whole local government area and beyond. Because one, the infrastructure there was meant for general hospital. Doctor, you know when you visited, the structure there is just not a private home thing. It is a big structure. And so the doctor, our doctor governor said, look, that place is going to be a referral for other areas around, the catchment areas. And as I confess today, I'm happy that we have gone that way instead of the general hospital. That is in 5 kilometers to the east and 5 kilometers to the west. Two general hospitals, but they're not as patronized as what we have today in our healthcare center. Yeah, we were also not able to sell the fact that they were going to pay and register 7,000 naira per husband and wife because their children, particularly under 5 and below, and pregnant women were going to be free. We have to market that. We have also to go to the neighboring towns and villages with prayer and the town prayers and the communities, the churches, to market this new idea. But it was difficult to tell them that there is something going to be a health delivery center, but it's not government. Anyway, since I have retired and I'm living with them, it was easy for me to go to community meetings and market for government. And they called me government hospital, politician, marketer. All sorts of names. Not until last 2 years, the doctors led by the chairman of the board, is it there? And Dr. Nkechika, they came and officially opened the place. Today, as I tell you, it is almost a medical center for people around. And even beyond where we have the normal government general hospital. So, with this success story, I hope government will continue to blaze the trail by leading Nigerians to go back and see that this key issue of our life, the health care of our people, is mainly in the rural areas. In the rural areas, if we're able to actually care for them in the rural areas, a lot will have been said of our government. What is worrying is that we should, since money is involved, we should make it more attractive than the other general hospitals that are already becoming a prescription center. Go to markets, go to Onitsha to buy this drug. We don't have that kind of knowledge to know which is the fake drug from these quacks that are around. So our plea is that as we are developing this model, which is novel to our people, please make sure that when the patient comes there, he will be given medicines, prescriptions from inside and treated from inside instead of referring them to the market so that they don't fall victims of the cracks. That will actually enhance their confidence and patronage of the hospital. Two is a situation where the doctors, you don't have to let them go at will. Please find a way to make the doctors stay by way of provision of accommodation, which we did, provision of even transportation, and making them to be part of their community so that you can retain them. Another issue is the issue of Nigeria generally are suffering from it. This migration or exodus of our expats. Please don't let the doctors come on weekly basis. Let them be there because we are ready to accommodate them. We are ready to make them part of our community. These are the few hints that I have monitored since 3 years ago that I think Delta State, under the leadership of our governor that is determined, that is knowledgeable enough, that has the push and the commitment to introduce this community-based health delivery system should be encouraged elsewhere in the country. I want to thank everybody, the facilitators. I want to thank the management, particularly my young man, Nkechika. He's Ben, I'm Ben, so I'm proud of you. The way everybody is calling you, I think I want to go home and tell our parents that you are doing very well. Thank you.
Thank you. Okay. So like rightly said, we should not let them go away, which is the doctors. Let me come to Dr. Wala. Dr. Wala, you represent caregivers under the Society for Family Health, which is one of the providers or participating providers on this program. Of course, that means you present the host of other providers seated here, MedBrew, Valio Medical, and the rest of them. Please, I would like you for a quick insight as a caregiver. What has been your experience in terms of patient encounter, even in terms of host community? What has been your experience? How do you think this can be encouraged to at least to drive home the issues surrounding not losing doctors who volunteer or come there to, establish and do their profession? Can you just give us a quick insight?
Yeah, thank you very much. Still standing on existing protocol, I want to thank the conveners of this event, and can only say this should be a bit more frequent because there is so much to learn from the partnership, and there's a lot of best practices that needs to be shared with other states in the country. Society for Family Health has been in existence for like 41 years now, and we ventured into service delivery, full service delivery in 2008. And the mission, the vision, the fulcrum of our service delivery intervention is quality. In so doing, SFH has a social franchise of about 360 private facilities across the country. So why I'm giving this little background is to elicit what we saw when we heard about the contributory health scheme, especially what's happening in Delta State. We got interested, and I must tell you that the Obio Health Facility, which our Honorable Excellency Chief Elue is referring to, is being managed by the Society for Family Health. One thing that has happened across in Delta State I saw is that right in these rural communities, you have very good roads, wonderful, express roads, and I really commend the state for this. This is very good, but not very wonderful for our implementation, because what that means is that you'll be busy walking, and then you'll see 2 or 3 vehicles driving, and then Dr. Ben Nkechika is in your facility. Or Dr. Oke or Dr. Alfred Ibiakofa is right there. And that's direct supervision. So you must be on your feet every time. Now, looking at our chief host here, our facility is just right close to his house, and he can stroll in at any point. So what am I driving at? At every point in time, we must be, on top of our game. And that has made it very, very attractive to the, the community, the rural communities that we serve. Now, the first thing that came to mind, that will come to mind, is health insurance. Will they pay capitations and all that? How will you make your money? Or at least make your money back. But what has worked for us as an organization is that we are not for profit. However, these facilities have to be self-sustaining. So what happened? Yes, we have we have 2 facilities, right? That we started with Obio and the Bogli Health Facility, and then we are prospecting. We have another additional 3 facilities that we are bringing on board. But what has happened is that the quality of service you give to the people that come to the facility determines your client flow. That is just, the principle of it. So we found out that even people come and say, look, I'm not eligible for health insurance, but I want to have my services. I want to have my family or my friends to, receive attention in this facility, and they register as private patients. Okay, so first of all, across these 2 facilities, we have over 5,000 enrollees. The commission is, on their feet, enrolling clients, and you also generate, a universe of private patients to support, the services. So you will always, as long as you maintain the principles of quality healthcare service delivery, there will always be that sustainability. Another thing I want to point out is what has already been said by some people here. The issue of quality of drugs, not just quality of service delivery. Drug quality plays a very crucial role. And again, one comes to mind when you talk about insurances. Are you sure I will get the best? Are you sure I'll get good quality medications? But we ensure that, okay, in the principle of bulk buying, bulk purchasing, we ensure that we get the best. And we also work with the commission. Another thing the commission does is to link the facilities, the providers to manufacturers like Sanofi. We had a partnership that was fostered by the commission with Sanofi, and other manufacturers. So you get drugs from the source. So it's been a wonderful partnership. I want to use this opportunity to thank the commission. The first time I walked into the commission, I thought I was in Society for Family Health. They replicate, what you see in NGOs, the quality of staff, the working environment, and their, responsiveness. They give you a listening ear, which is very important. So I want to thank the commission for what they are doing. Of course, beg for more, attention in terms of resolving some little, differences we have in invoicing. And then I want to thank our chief host and the other communities. Now we are moving into Ereni and Ibodo as well as Ejemono. And we are forming what we call a hub and spoke model where Obio Health Facility, because of all the infrastructure that is already in place, there will be like a referral center, like a hub, and then the other facilities will form as a spoke. We're also looking to work closely with other providers, the Pelion and the other my colleagues here, to also have what we call what we want to propose as a community of providers. So we have we leverage. We want to leverage. We want to integrate our services because we are serving the same people. So it's been a wonderful experience. Society for Family Health is very proud and very happy to be part of this experience. One of the off-takers, my MD is here, stepped out briefly, and all my other senior management are online, and we are all very happy to be part of this. Thank you very much.
Thank you. Thank you very much. I think maybe we'll target providers of the underserved and hard to reach areas. Maybe we can start looking at a branch of HFM for that. Let me come to Dr. Oke. Basically, I know that this program has been laudable, but of course, we didn't just get to there. There has been a lot of work that has gone on there. And of course, I'm sure Dr. Ben couldn't have done everything without having his two ICs on board. So in a nutshell, tell us how it has been to engage, to bring this scheme to limelight, especially engaging providers, the communities. What are the critical things that needed to be put in place to achieve or to realize where we are today?
Thank you very much. Still standing on existing protocol. I would say that this program was conceptualized to improve access to quality healthcare services for community residents in medically underserved and rural hard-to-reach areas. So as the commission was signed into law in 2016, and one of the core, in fact, the major mandate of the commission is to ensure that there's access to quality healthcare services for all residents of Delta. So some of these areas were identified where they actually were medically underserved, so they didn't have access to these facilities. In one of the Director General's visits to one of these communities, he asked, for their hospitals and they showed him a hut. So like, oh, this is where we receive healthcare. And he looked at it. Of course, he knew that this was not a hospital. So he asked, okay, you have a doctor in this community. Can I see the person? And one elderly woman came out and he asked this woman, are you a medical doctor? This woman was not literate. He knew, of course, she wasn't a medical doctor. It happened that she was the wife of the chemist who had been providing care to the community residents. Chemist had died and then somehow had passed on the tradition or the profession to her. And of course, you can imagine when he told them, okay, so I'm going to bring a hospital to this place that is going to function. They told him, whatever you are bringing should not be worse than what we currently have. And in his mind, he asked, what really is worse than this? And this is really what, is the story, the reality in some communities. This is all they have as access to care. Some traditional vet attendant somewhere, somebody that probably just had some few medical knowledge and the person is, just passing this on. I remember as a copper during my NYC years, I went to one community in Benue for a program and there I met this, it was a true that I was running the hospital and a woman came, it was a HIV program that we had to prescribe drugs to sorry, I'm digressing anyway, but just to buttress a point. So they took doctors, copper doctors to different community hospitals, to prescribe drugs to HIV positive patients. And then we got to that community and a woman came and she was so sad, she was so downcast. And I asked her, oh, what's wrong with you? She said she has uterine cancer. I said, you have uterine cancer. How did they diagnose it? The CHU immediately came out and said, please don't get involved in that. Just treat the HIV that you came for because we can diagnose, we can treat, we can manage. And I said, so you can manage uterine cancer. This place is maybe like 1/8 of the size of this place, very small. And then the person in charge was a CHU that had worked, a junior CHU that had worked in a hospital, in a primary health center, and said, so you can treat uterine cancer here. She said, yes, we treat it. In fact, we even treat, and start calling all sorts of diagnoses that even me as at that time, I could not even manage and all of that. And that is really the reality this is the reality in some communities. That is all they have as healthcare service. And this is one of the reasons why this program was designed, so that people in these communities can actually have quality healthcare services. So when we started this program, we first of all, when the idea was conceptualized, we had to keep refining it to what it currently is today. We had the needs assessment, the gap analysis, went to different communities and all of that. And then we refined it to the current framework that we have. And then we sought approval, from His Excellency, the Governor, which he willingly gave. And then we started to identify, the private providers, determine the contractual, the terms for agreement, engagement, and all of that, and even determine the implementation guidelines and all of that for the program. So when we ran through that, the program was launched and these people started to provide care. And when we started, really had, of course, it was a new program, a novel thing, and it had its own set of teething problems. So we had some community resistance because we did, despite all the intensive and extensive advocacy and sensitization that we did, there are still sects of the community, like Chief Elwe had said, that believed that, oh, you people want to come and hand over our facilities to private providers, and they resisted the private providers. So some private providers visited, when they visited for their own baseline assessment, some community sects just rose harness private sector participation. We also have ensured that there's adequate distribution of healthcare facilities. And then we've been able to have alternative sources of funding for the health insurance scheme. So the government, there's an improved confidence, renewed confidence in government health programs. People normally don't even believe in government health programs. And we were very fortunate to, have a similar name to contributory pensions, which had some issues. But with this access to finance program, there's a renewed confidence in government health programs. And generally, there's improved health outcomes in the state. So it's actually been a very laudable project. It's had its challenges. It's a work in progress, but we currently are working around the clock to see how to improve the challenges. And just as I conclude, I really like to thank the Delta State government for creating an enabling environment for this partnership to thrive. And for this very dogged, every day I salute the courage of our dogged private providers through flood, through high waters. In fact, the first time I went to one of the communities, 4 hours on boat, I prayed throughout. And while I was even in the community, I could barely concentrate. All I was thinking was, how am I going to get out of here and get out safe? So it's an experience that, and we have private providers that do this every 2 weeks. Their staff moving and then they move out, they move staff, property. Imagine the risk. And thank God there's really been no loss, but imagine the risk transfer, moving your staff, moving your property, and then 2 weeks again, they are out. So I actually salute their courage and I want to thank you all for your input in this program. Thank you very much.
Thank you very much. Interesting. We prayed through Ultra and prayed back. I will keep on praying. I think I remember some of us were sleeping instead of praying, but that's very insightful. Quickly, because of what you just mentioned, let me come to Chief Nelson. Twofold, you are the community leader as well as I'm reliably told a patient of that has utilized this facility. So I want you to give me your perspective, basically as a community, how the community has embraced it. What are the changes that happen in your community? And then as a patient, your experience, you've experienced and probably what you supposedly expect to happen and how it can be acceptable by the community. Thank you.
Yeah. Good afternoon, ladies and gentlemen. I think I must have to stand on the existing protocol. My name is Nelson Ogelegbanwe. I'm a high chief from Bamatu Kingdom, number 3 chief in the kingdom. And the hospital is in our community, in my community. Like what the chairman said before, I think this program, when the program came into existence, initially we thought it was a joke and that no good thing will come out of it. That was our thinking. Because most of us will believe in our herbal medicine and not this type. If you are sick, they will go to the forest, give you some leaves and herbs, you go like that. So we don't so much believe in this one. But when the thing come into existence, like what we heard from the preacher in the Bible, they call some 2 persons. One is Silas and the other one is Paul. When they were preaching in Antioch, something happened. There was a big miracle. So because of the miracle, they described these 2 persons to be that they are God. So they become afraid. They say, I'm not a God, I'm a human being now. So they tore up their wares and ran away. So what I see in this program, the Delta State government and our DG in this program, we've got another new God in the kingdom. Because from my community to Warri, it's almost 4 hours drive. And if you have any problem, before you drive from my community to Warri, you are going to mortuary. You are not going to hospital again. Straight to mortuary. So that anybody you move out of the community for treatment is to mortuary, but not to hospital for treatment. But since the existence of this hospital, I think we are enjoying it. They save most lives. I think for the past time now, I've not seen somebody who has died in that hospital since the existence of the hospital till now. Anything you can think of, both operation or anything you can think of is successful. And the doctors, they are 24 hours. If you like, go 5 o'clock in the night, 2 o'clock, 12 o'clock in the night. Immediately as you reach the hospital there, doctor, nurse, everybody's ready to take care of. So I think I thank Delta State government, I thank the DG and people who are in charge of this program. We want them to do more. Like what the other, this noble said, Oliver asked for more. So we ask for more materials, more people to take care of us and to save more lives. Thank you very much, and I stop here.
Thank you, sir. Before I open up for maybe possible questions, which we can take, I'd like to have 2 people to corroborate, especially because I like to balance gender. Dr. Nwala has talked about what they do, but I'd like Dr. Onya, if she's still around, and Dr. Itunu, who are also private providers to this scheme, to come and corroborate exactly the experience as well. And, you know, let's hear from the female perspective, because, you know, to ensure that it's not only men that are ready to take risks, but the women also are in this to take risks in making healthcare a better place. So please, Dr. Onya, if I can see you're available.
Good afternoon, everybody, and thank you for the privilege of saying a word. Already jotted notes, because if I speak extempore, maybe Dr. Ben will get rid of me. So I'll be, just to make a little difference, not only are we female, Itunu and I, we are also both running organizations for profit. We're not for profit. So first, I will say it's a privilege to be on this program, and I honestly consider it a privilege. Somebody started I think it was Olumide, started very diplomatically by saying another state should have started this. I was a part of the people who were to start in the other states. And I remember introducing myself once at a meeting, and I said Ngozi Onya, and I heard a comment, Shogbo Yoruba. And so I took him up and I said that meant to be a tribalistic comment. And then of course so when Delta State was starting, I was very pleased that nobody will ask me comments. I'm a daughter of the soil. So it's a privilege to be there. That's number one. Also, there's no doubt that it has increased access to healthcare. You know, I see people who come to the clinic. My hospital was the beautiful one with the, I'm also proud of that picture, with the generator. That's my own health, the one in Amai. So it has increased access to healthcare. The kind of people coming there are people who ordinarily will not have sought healthcare. So that's also very rewarding, because as a doctor, my primary focus is on saving lives. Making money is just a healthy accompaniment to saving lives for every doctor. That's the truth. No, it's for every doctor. We would like to make the money because we need the money to live. But the primary, I mean, there were easier courses to do. The primary focus of every doctor is to save lives. Okay, then also, something that was very impressive to me was when I joined this program, I was given 2 health centers. The one in Amai, I went there and I found all the equipment that had been bought 8 years previously, locked up, exactly the way they were delivered there. None of them haven't been opened, very well kept. Even the deep freezers, so even if we say the hospital beds are not useful and so on, but what about the deep freezers? They were locked up. And I thought to myself, this is an honest community, a community to serve. And I'm glad I found it to be so. And then, of course, I got a lot of goodwill. So that big generator you saw out there, we didn't buy. IHS Towers donated to us. So we got support because it was something laudable. and it was something to be supported. I must also say that the community was very supportive. Something that Delta State got right, in my opinion, is that they engaged the community in a way the other states didn't. So we didn't get a lot of resistance. So we have an advisory board, and the Prime Minister of I've forgotten the name of the little community in Amai where we are, but the Prime Minister is the chairman of the board, and we meet periodically. So we have the buy-in of the community. And then, of course, I must say that the Delta State Contributory Health Commission has been extremely responsive. Like somebody said earlier, sometimes at 2 a.m., I send Dr. Ben a message, hoping he will reply in the morning. He replies that morning at 2 a.m. And of course, Dr. Can I have a regular battles, but I find them extremely responsive, and I'm grateful for that. Like Sunday said, it is a work in progress. So we can't make it look like it's El Dorado because it's not. We have our challenges, sometimes delayed payments. We have our challenges. We all know what's happening to the Naira, the exchange rate of the Naira, the prices of the drugs skyrocket. Meanwhile, we are only being paid a fixed sum. A good example are intravenous fluids going for more than 1,000 Naira. I think we get paid 120 Naira, but we buy them for 1,000 Naira. What do? Do we let people die of dehydration? No, to do that, some of the challenges that need to be tweaked. Also, the issue of security. Dr. Ben was lucky when he was going to the riverine area, he had security men, and he's a man. So you can imagine me wanting to go to all these areas. My brother was saying, Ngozi, you're on your own. If they kidnap you, I'm not paying ransom. So the security issues are a challenge. And I really wish they can be tackled, because if they are tackled, I will have been much more hands-on than I am. And I'm sure we will have achieved a lot more success if I had been more hands-on. Now I'm doing a lot of remote management. Then, okay, I think I've said most of what, the roads. So it's interesting that you said there was good access. The big challenge I have in my location is the road. There's a tiny stretch of road, which is less than 1 kilometer, but it's totally unmotorable between, maybe that's why Dr. Ben doesn't visit us as often as he visits you. Maybe we should leave it that way so they won't come and check up on us. But on a more serious note, that road between the Novena University and the health center is unmotorable. And I'll be really, I've done everything I can. I've written to everybody, including the governor, 20 messages. I don't, whether you read them or not, I can't tell. Anybody I know, please help us tar the road. So Dr. Ben, please help us tell the governor, help us tar the road. Between Novena University and the Amai Health Center. Pardon? It's not a problem. I don't think it's, but it's totally unmotorable. So thank you for the privilege, everybody.
Thank you very much. Of course, where there's they say where there's a will, there's a way. And we have seen people with will, and we definitely know there'll be a way. So let me call on Dr. Itunu Akinware. I think the first thing I will ask is Shobo Yoruba or Shobo Enuani. So that's to tell you how laudable this scheme is, where it's not about tribe, it's about functionality, competencies, and putting it together to make it work. Dr. Itunu, welcome.
Okay, still morning, oh yes. Afternoon. Good afternoon, everybody. I stand on existing protocol. This is very interesting because when I got a call to come here today, I actually already had a pre-planned meeting in Ondo. But then primary care and grassroots care is so important to me as a person. And I realized that if there was any opportunity to come and speak for it or speak to the importance of it, I had to be here today. And that's why I'm here. I have a gentleman with me. His name is Dr. Philly. Thank you. Right. And I'm going to say a bit about Medbury Medicals, because a lot of people might not know who we are. We're actually an integrated healthcare service, an institution that is involved in various parts of healthcare. So we do diagnostics, we do occupational health, we supply pharmaceuticals, we do quite a number of things through various business units. And one of our business units is providing primary healthcare. And the reason why I asked Dr. Philly to come is because he that has been running this for a long time. And please, if you could just help me give him a round of applause on my behalf, because, you know, sometimes the bosses come to speak, but there are people that actually do the work. And these guys, he has a team that works with him. There's a gentleman called Dafe that he isn't here today, but even in his absence, I need to say thank you to him and to the entire team. Please, just one more time, a round of applause for them. Thank you, Dr. Philly. I need to say it publicly, so you can go back. So they've told me what to say, right? And I'm going to try to say it. I'm very happy to say that, you know, I don't speak the language of those in Delta. However, I cannot say that I've been met with any kind of tribalistic behavior. I cannot say that other people that have come from there have gotten better opportunities than I have. And I want to thank Delta State for that, right? I'm actually from the other state that says Shogbo Yoruba, you know, and nobody asked me that question. But I'm going to tell you a very short story. I remember when we signed the contract and I went there for the first time. I went to the environment myself, somewhere in the Riverine area. You know, they kept driving in a Hilux. I was like, are we not there yet? Are we not there yet? Hey, God. You know, and we got there and I got to the existing primary healthcare center. And I said, oh, let me speak to some of the nurses. And the first thing the nurse said to me was that, can you imagine this wicked government? You know, they told us that we must be thumb printing. That means I must come to work every day, because if I don't come to work, they will catch me and they will not pay. I said, I said, you know, I didn't want to say, are you serious? I said, oh, the government is very wicked though. Imagine, how can they do that to you? You know, just to get as much information. I went through the place, there was leaking roofs, there was mold on the wall. Somebody came and said, you know, rats and bats are in one place, so they've abandoned it. It was really terrible, to be quite honest with you. It wasn't, you know, it wasn't a place that people would want to go to, right? And that even made us even more excited to get on this program, because we knew we could make a change. And I'm going to say something now. The reason I gave that introduction about who we are is because we've had the opportunity to provide healthcare to the 1% of the 1% of Nigerians. But I can tell you today that the most fulfilling work we do today, the most fulfilling work I do today as an entrepreneur and as the MD of this company, is the work that I'm doing in Delta State. Because being able to provide healthcare and save lives and see babies, when we have this WhatsApp group that whenever, you know, there's a baby or, you know, something has happened, they post in on it, and we're on that group and we're also very excited. You know, sometimes, you know, we just do, thank God it's Friday for our people in Delta State. We throw a party for them because of the kind of work that they are doing. I see my people get on canoes, right? I see my people jump on boats. I remember there was a time that the road broke into two. There was no way to pass. You know, it was a real, and we thank the government because the government fixed that road. A round of applause to them. You know, in Nigeria, many times people talk about what the government is not doing. We need to talk about what the government is doing as well, not only what they are not doing. And we will stand and we'll speak right. And I remember when they gave us our facility, we fixed it up, you know, it was beautiful. Then the rains came, I think Dr. Ken mentioned, and carried our facility away. Literally, we have the pictures. And we were like, what are we going to do? There's no other facility in Akubene. And we said, okay, what can we do? And we actually, because of our doggedness, because of our passion, we actually rented out, I think, a 2-bedroom. No, before we rented out a 2-bedroom flat, the community king gave us a 2-bedroom flat that, you know what, starts with this place. And we started with the 2-bedroom flat. In a couple of months, it became too small. We had to rent out a 4-bedroom. Now it has become too small. We need to expand again. You know, And one of the things I want to say about, the commission and what it did well is choosing the right partners. Because when you are starting something, it's not always pretty. We have had the opportunity to be the scapegoats. We are piloting this. We've been the scapegoats. The commission has learned. We have learned our lessons. We've had our fingers burnt in some things. We've known what to do. We've known what not to do. But we believe that we've laid a good foundation for others that are going to come after us. And we know that those that are going to join the commission, and as we continue to grow and join the program, are going to get even a better experience. And we are very grateful for that. And I would say that there was a lot of support from the commission. Yes, there are times you go for a meeting, and if you know Dr. Ben will say, no, this is how it is. No, if in his usual nature. But, he will listen to you. He will take the feedback. He will go and think about it. He will come back and say, hey, that thing that you people were talking about. The last chat I have with Dr. Oke is at 3 a.m. in the middle of the night. Because I think they paid us one invoice. And I'm like, somebody just said that, this invoice is not complete now. I didn't even know what the time was. If you're an entrepreneur, sometimes you lose time. Time doesn't exist. It doesn't matter. Anytime that's, and I just sent her a text message. Dr. Okay, what's going on here? You people say you have changed now. And I just looked at the time. I said, oh, I'm so sorry. I didn't know it was this late. She responded and explained everything, told me, gave us the reassurances. Dr. Biakofa as well. We've had multiple conversations. And I will say something, as I said before, when you start a thing, it's not always pretty, but it has to get better. The most important thing is the commitment to continuous improvement. And I see that in Delta State. And I want to thank everyone because that support has been there. I heard my colleagues say a few things around, optimizing cost and optimizing care. When we started, we would buy drugs like the regular drugs that we will use in our Lagos centers until we realized that you need to learn, you need to optimize cost. So there are a lot of things we've learned, and I feel that there's a lot of things we can give in terms of feedback and things we can do better. Definitely, we are always Oliver Twist. Please, if you can help us adjust those claims, adjust those, exactly. If you can help us with increasing that, that will really help because it will help us with break even faster and it help us to bring people in. I think that also in terms of the facilities, and I think we need to scale this up. I'm here today. If there's anything you hear from what I'm saying, it's not perfect, it's getting there. But I think that this is a sustainable way of providing healthcare at the level of the grassroots. And I hope that the policymakers, and I'm speaking as a private sector person, I don't need to come here and say this. If I didn't believe in this project, I won't come. I don't have to. I'm in private sector, I don't need to come and say what I don't believe. I do believe that PPPs is a way to go. And I think that we should find a way to make it happen, make it work, and scale it across the country. Thank you very much.
Thank you. Thank you very much, Dr. Itinu. Dr. Ben permits me, I heard the community online are itching and striving. And so I have Dr. Joseph, basically representing outreach. I think it's Dr. Shegu Ebitami, who is online. I just want to throw a few comments. These are one of the people that are even asking for over 100 facility. I don't know why. So please, Dr. Shegu.
Good morning, everybody. Don't know if you can hear me. Uche, can you hear me? Hello, Uche, can you hear me? Hello, Uzo, can you hear me? Wow.
I can hear you. I can see you.
Okay, good, good. Good afternoon, everybody. It's wonderful being part of this program. We joined the Access to Finance scheme with a vision to expanding our access to underserved communities. Our experience in Ovade has been very tough, We met a very rundown facility. I'm happy the presenter showed the picture of Ovade before and after. And we've seen over, at the last count, we've had over 5,000 encounters, over 1,000 deliveries, and not a single death. Before we got there, they used to go to traditional birth attendants. Mortality rate was high. And more importantly, one of the things we've even brought to the community, it's educational access. People come to our center to do lessons and even recreation. We also supply water, more or less, to the Ovade community. So it's been a very tough, very rewarding experience. And we are hoping to keep on keeping on. Right now, just as Dr. Onye and Itunu said, one of the places we are having problems now is with the funding. The scheme has gone through different phases of evolution. From a fee for service, now we are looking at a capitation-based scheme. I believe capitation is the best way to finance healthcare, but the capitation must be appropriately priced. Right now, I think we are still tinkering with it. I'm not sure we have the best point yet. But be that as it may, I believe that it's a program like this that is going to be the solution to healthcare in Nigeria. I honestly believe government is never going to be able to do it alone. Private sector efficiency is what will eventually deliver value to Nigerians. And government, as usual, has the infrastructure. There are 30,000 primary care centers in Nigeria. Less than 50% are active. So private sector efficiency, leveraging of government infrastructure, to me, no matter how well we look at it, that is what is going to solve our problem. So thank you, everybody, and I hope we continue with this discussion. Thank you.
Thank you, Dr. Ibitami. So quickly, before we go into, I think we'll just take one or two questions and answer. Let me quickly recognize, before question and answer, please. Yeah, please, I want to recognize the presence of the former Commissioner for Health, Lagos State, who had just graced our occasion in the person of Dr. Jide Idris. You're welcome, sir. So quickly, questions and answer. We'll just take a few questions and answer so that we'll quickly take a photo session with the panelists. You can direct your question to whoever you want to get the answer from.
Okay, my name is Dr. Kingsley. I'm the Chief Economic Advisor to the Governor of Delta State. First is to commend pharmacists for this invaluable, very invaluable intervention, because without you, all of these tourists can never be there. Second is to underscore the role of private sector in exercises like this, because the civil servants will never go into very remote areas to do the kinds of job that private sector will. They don't have the determination, they don't have the zeal, and they're not as committed as you will be. Third is to also factor in profit. So to make your business more robust, it's a good thing that you are starting from orphan centers, so that's where you went to. I knew the battle between Primary Health Care Agency and Dr. Ben's program. So it's good that you started from the orphan centers, but I will also suggest, Ben, by way of compensation, that 2-3 orphan centers, 2-3 urban centers. I think that will mitigate the managed economics of what you're doing, because it's a volume game. It's a volume game. So once you have that volume run, some of these agitations will be minimized significantly. The other thing is to bemoan the absence of multilateral and donor agencies on this occasion, because this is a testimonial. You are trying to demonstrate to the world that it has happened and it can happen. You can never have a hitch-free program of this nature anywhere. And then for the policymakers, that the Primary Health Care Agency and the way it is structured should also be looked at, because the fight between primary healthcare agencies, the constitution as it concerns primary healthcare by local government authorities, is something that we must also look at. If there are benefits, grants that are accruable to primary healthcare centers that creates that challenge of not allowing private sector use the facilities of primary healthcare agencies, I think it should be addressed urgently, because that will free up the kinds of mix that we require to ameliorate the economics that you already suffer from this challenge. And the dearth of or lack of very strong representation, like the most distinguished senator said, is also very critical, because we must begin to take testimonial exercises of this nature and take them to a higher level. If you send in very junior officers who can make major decisions, then you have a big challenge in appreciating the situation that will have experienced. So I plead that we do a recording of most of this session, the testimonials, and then send it to the highest level for policy intervention. Very critical. Delta State is a microcosm of Nigeria. The good, the bad, the ugly. You can't even say bad infrastructure, good infrastructure, riverine areas, hinterlands. So we represent Nigeria. If you can do it here, you can do it better. I can't see NGF here. I can't see the presence of policy players here. So this is a significant setback. So if we need to do this again, then we must ensure that all of these people are present and or send the tips, if they will be patient enough to make sure that they go through the entire process. So I like to commend you, because you are actually the major driver. And then commend the other people who have agreed to participate on this program. And then, Mrs. Sonia, sorry, I didn't see you on time. I should have said hello. So I'd like to thank everybody for coming. And Ben, I don't need to thank you. I can't thank you enough, because you are already assimilated in this program. God bless you, and God bless the Federal Republic of Nigeria. Thank you.
Thank you for the comment.
Thank you. Your Excellency, good afternoon, ladies and gentlemen. My name is Aniago Charles, Honorable Commissioner for Information, Delta. I'll ask my questions from the base of three premises. One, the comment by Njideka Ndili when she did mention that she expects other states to emulate the Delta example. Two, from the anger very well expressed, even if subtly, by the chairman Senate Committee on Health, that I can rightly say is the #1 lawmaker in the health sector in Nigeria today, where he mentioned that he wasn't so pleased that the Minister of Health is not present at a function like this. And then the third ground is the conclusion by Dr. Nkechika, when at the end of his presentation, he said to be continued. And on the ground of that to be continued, I want to ask him a question, because saddled with the responsibility of assisting them to sensitize Deltans on what they are doing at the level of the commission, I have, though not being a doctor, been able to also have insight into what they are doing. And one of the challenges I want him to address is the issue of health providers who often or sometimes come up with fraudulent claims, in which case you may not have treated somebody of a particular ailment, but because you know there is money to assess, you come up with a bill for the purpose of assessing that fund. Secondly, the issue of also verified claim by the health service providers, and it takes you longer than necessary to pay such verified claims, even in the midst of a bouncing naira that changes even in the morning before the evening. In which case, if you are owing somebody today and you spend 2 months before you pay, the value of what you are owing that person may have changed. So why I linked it up with the position of the lawmaker is how much legislation are we going to introduce to deal with those who may come up with verified claims and what will be the penalty. And then what will be the interest rate if there is a delay beyond a certain time of not paying a verified claim. So I'll be glad if Nkechika takes us through how they have been able to manage such discrepancies that may arise between the treatment, so that you don't treat somebody of malaria and you come to say that you have done some operation that will cost more. Thank you.
Okay. Good afternoon, everyone. My name is Aluko Oladimeji. I'm the Director General for Kwara State Hospital Management Board. I want to also commend the Farm Access Foundation for this laudable project. Indeed, it's mind-blowing. And for anything else I was doing today, I had to set it aside to be here. And I want to particularly say that the senator, who is also my senator in Kwara State, I'm really proud of him. A lot of positive strides in healthcare, service delivery in the country. I'm really, really proud of you, sir. You know, I said to people, COVID-19 was the best thing that's happened to mankind. And people look at me, they think something must be wrong with me. The reality is that for the first time, even your neighbor, your neighboring state would not or were not ready to give you access to care at those crucial times, because all they were concerned about was their people. So it's very critical we understand that the mandate to give quality healthcare to our people becomes a responsibility of the government. Like I said, I manage 45 hospitals, which are secondary facilities. But part of the reason why I'm here today is to understand how the Delta State have been able to do this. Two things. The community, it's one of the most difficult people to convince. In a political time like this, any government policy, you will see oppositions that are ready to kill your idea even before you start it. So for instance, like His Excellency mentioned earlier, if you bring three ideas and you want to develop in a community, what people will say is, one, you want to sell our facility. Two, you know, it could be, for instance, the nomenclature. So one of the biggest problems we're also facing is that what is the difference within a general hospital, a primary healthcare facility, a comprehensive health center? These are important issues. And I want to quickly say this, that government does not have, they're not good at business. The best way to actually manage our healthcare is through public-private partnership and interventions like this, without a doubt. I have submitted a lot of proposals, for instance, to Kwara State government, at looking at how we can partner with private entity to run institutions and, in fact, indeed, to do equipment placing and public-private partnership. Dr. Itunu can bear me witness to this. But one of the biggest problems is that the community will always believe that a politician is coming to sell their property. Now, I really want to understand, and I'm throwing this question to the panelists, that how did you manage to convince your people? And how do you raise above political interferences and community battering you left, right, and center to be able to achieve this? It's very critical, so that I can take this along with me as a lesson back to the state and see how we can circumvent this issue. Thank you very much.
Okay, before we take further questions, maybe we'll take quick reaction. I think the first one, of course, is directed to Dr. Ben. Talking about, the first was a comment, but the next one was talking about healthcare providers who come up with fraudulent claims, and also how to manage verified claims in terms of addressing and improving efficiency. So let me quickly hand over the mic to Dr. Ben.
Thank you very much. The beauty of this program, I don't know where to stand. Okay, the light, yeah. The beauty of this program is that there was a well thought out process and procedure. So we did an extensive research, and we have what we call a framework, a product paper, and an implementation plan. And we realized that one of the most critical situations was going to be financial. Because in as much as we're talking about healthcare, this program is actually access to finance. It's all about financing. It's just that the provider is there, the patient is there. So when the issue of claims management started coming up, initially we were manual, but we decided to go digital, because the first question about whether a claim is correct or not is, where is the evidence? And that's why, as I stand today, every facility under the scheme registers the patient electronically, sees the patient electronically, the bill is transmitted electronically, the claims management is reviewed electronically, and the information is sent back electronically. And I'm talking of about 400 facilities from the primary healthcare center. In fact, it was so serious that most of the nurses in the primary healthcare centers that were not ICT enabled employed their children to man the ICT system, and they were paying them with their private money until we realized and we started supporting them. That's how serious it was. So with that, we're able to ensure that the claims that come in are proper claims and verified claims. Let me digress a bit. There was a day a facility said we did not pay them the right fee. And we said, come. And we opened the system and showed that provider, not an access to finance provider, let me be clear, but it's a provider, that they actually charge us cesarean section for a man. And they were surprised. Reason is that when they sent us the bill, they said it was a female, all the data, but every patient has a backup back end. There were sometimes we received bills, and for every service given, the patient has to sign. And we noticed that the signature was one kind. We saw the phone numbers, it was one kind. We went back to our back office and verified and started calling the patients directly with the original phone number. Most of them said they don't even know where that clinic is. So those are the kind of things we have seen. But what I'm trying to say is that claims management is a dynamic process. It's subjective. I could say a bill is not correct, or the commission can say a bill is not correct. We are not there when the service was provided. We're only dealing with the evidence we have seen. The doctor will come and explain, because healthcare service is so dynamic that you cannot use the same parameter to treat two patients. So we are not there, so we only say it's not correct based on our understanding. Most times they come, they clarify, and we pay. The ones that are not clear, they will say we are sorry. Sometimes they tell us, we are sorry we made a mistake, can you pay? I said, my law does not permit that, and I will not pay. But in terms of how they're able to survive, that was why from day one, we said every provider in the Access to Finance program must take a loan, single digit, so that they don't come and tell me, you know, you are owing me money, it's taking time, I took bank interest, I took bank loan, it's 28%. I said, no, it's 9%. I will give you 1 year moratorium and all that, so that we always manage those issues. Yes, we are not perfect. We can have manpower challenges. We have this situation that we have to manage. But as much as possible, there was always communication. There was always discussion. At no time did we shut our doors. So we can talk for 5 months. We can talk for 6 months. Eventually, we will settle. And when we settle, there's that understanding. And also, we also make them realize that it might not be profit today. It might be a loss today, but there's a possibility of a recoup later, because we help them and we support them. And that has been able to help them manage us when we are owing them. And sometimes, yes, like Mrs. Sonia said, me and her have had a 2-hour discussion from 2 to 4 a.m. one day, and she was surprised. And we argued, we talked, and the next morning I called her back and I said, Madam, yeah, you know, yesterday was very hot. I called in Jide. I said, Jide, please help me beg Madam that yesterday was hot, but today is cool. And we're best of friends, and we'll continue. I mean, Dr. Ntinu has been very helpful. Sometimes I wonder how she survives in Akubene, but she's quite dynamic. And so many other providers. There was a provider that we had challenges with, and we told him, sorry, we cannot pay your bill. And he looked at it and said, okay, I didn't come into this. And he wrote off the bill. But when he wrote it off, and I said, come. We don't want you to get angry. Let's look at this, your bill again. Let's see, maybe there's this mistake we have made. And we started looking at it. And today, he has not only started with 2 facilities, he's currently running 8 facilities. And that is what we try to do. So it's a dynamic process. Nobody is perfect. We'll continue to work on it. But one key factor is that no matter how long it is, we'll continue to discuss it. We'll continue to argue, and eventually we'll resolve and settle. And we always try to find ways to create that financial enablement that accommodates their risk, accommodate their losses, and at the end of the day, they are quite happy and comfortable. Thank you. For the second question about how we're able to manage it, that one I think we'll have to sit down and talk about it, because there are lots of unorthodox methods we had to do. If I tell you some of it, some people will say it's not possible and it's strange, but we can say that. But one thing which was very useful is that treat everybody on equal basis. The community leader, respect him and give him his due. The provider, do the same thing. If you put everybody on the same table on an equal basis, they respect you. You know, when Taye is a chairman, the first day the governor said, go and talk to Taye, I was expecting one huge man. And I called him and said, Ben, where are you there? I've never met him. I don't know him. He said, I've just arrived, worry. He said, come here and meet me. When I went there, he just brought out 2 plastic chairs and we sat down. I'm like, so when is the chairman going to come? He said, no, I'm the chairman. I said, what can I do for you? I said, this is this. He said, no problem. And whenever you're ready, let me know. And that was it. So if you relate to people, when I go to communities, I sit down with them. I follow them into their inner caucus. If it's football, we'll start playing. Once you build that relationship, then for government, the biggest problem is actually government, not even the community and co. You must learn to have your empirical facts. I want to thank Dr. Kingsley. I know he hasn't said it, but he is actually the person that actually guided me through this entire process that we're having the success today. He was the chairman of the economic management team that did a critical review and wrote a recommendation to the governor that the governor approved for this program to start. Thank you very much, sir.
Thank you, sir. Thank you very much, sir. I think there's one more, just a follow-up to Dr. Aluko's question, which is to the community. How did they manage to convince their people, I guess? Can I direct it to Chief Benjamin, to please tell us how?
First, I live in the community. I've retired from Asaba job, political job. So I live 24 hours with my people. We go to church together. We go to town meeting together. And I have opportunity to relate with them at the grassroots level. That's number one, communication. 2, once they started and people went and tested the food and saw it was sweet, it was easy for them to come back. So here is the question of efficiency. Efficient delivery of healthcare makes them come back again. The test of the pudding is in the eating. They tested it and they saw the difference they are bringing into their lives. First, it was the issue of paying that 7,000 registration. At a time, we were able to go in to compare what is life and 7,000 naira. And over the time, with the kind of services they were getting, they found out that it was easier to pay that 7,000 naira and care for about 3-4 people in the household than to go to the chemist shop, who are already becoming doctors in their own rights because there's no competition, than to pay the 7,000 naira. So they started registering. More importantly is that they got very efficient service. They can confide in them. That's why I'm pleading that the quality of service you are now rendering should not be mitigated at all. Please keep up the standard. In terms of the physical structure, you have gotten it. But maintenance, if you get there, you'll be surprised that is this one what you call healthcare center? They say is a teaching hospital already. Because with the few committed staff you have, people are convinced health is wealth. And the realization of that is that our people are more interested not in the money or the cost or who owns it now, that tripping down to the place, especially for the pregnant women. Like people testify here, we've not had any miscarriage in that hospital. We have not had what we're having. In fact, the town celebrated the first successful birth in that hospital. Well, the people now call it hospital, instead of saying whether it is health center or not, because of the services. My friend from, thank you, go home more often, live with them, convince them through all the channels, and they will follow. I find it easier to communicate with my village people than the politicians. Once something is right, they follow. You know, that is how it works. When you operate at their level, they appreciate you, and they follow you to where they believe you are enjoying your life. That is one critical thing. I've said, please make sure that the hospitals are not turned into where you just refer them to go and buy from outside. They will fall into the problem of buying from quacks or these initial traders going around every morning. Please, I think it is their efficiency that one good turn deserves another. They will come back once they know the place is well run. Thank you very much.
Thank you very much. I think in the absence of further questions, or just to address, I think there are a few questions online we can quickly address. Someone asks if there has been some financial analysis and if this program is sustainable, asking if the providers has broken even. I can attest that yes, there was financial analysis. Some providers have broken even, and some, they of course, will soon break even. That's the way it's done. The other one talked about concerning issues concerning migration. I think it was initially addressed in terms of how can we stop or reduce migration. And if I rightly remember, that we were told to try and accommodate and provide better environment for the doctors that are actually providing this care. This should actually encourage them, to retain their services within the community. Other questions we'll try and address later. But finally, I want to invite the board chairman to, and help us close this session. Who wants to, finalize with a comment? And it's important. Let me invite Dr. Isaac Apoveta to please for his final comments on this session. Miguasa.
First, let me thank everybody here. You've made our day. Before 6 years ago, about when the governor was rounding up his campaigns, I remember the first call I got about this commission was from then it was the Commissioner for Economic Planning, Dr. Kingsley Mo. I got a call on my way to Asaba on the day the governor's transition committee was inaugurated. And when I got there, I met him. He said, oh, His Excellency said we should go to Lagos to attend a roundtable talk on health insurance. We left Delta at 12 o'clock in the afternoon. Dr. Ben, myself, and one Dr. Modo. We drove throughout the night and we got to Lagos about 12 midnight. And the next day we attended the roundtable talk. That was our first introduction into this commission. One person that had been very helpful to us that told us one thing, and I never remember, I'll never forget it, Dr. Kingsley Mo. He said, buy and pay for your success. You can't be successful in whatever you are doing without paying for it, with your time, with your money, with your effort. Dr. Kingsley, thank you for that comment you made many years ago. So today we are here. We are organizing the scheme. The front runner is Dr. Ben. We are on the background supporting him. And we are very grateful that Pharmacists came in. Even the other agencies that have supported us so far. We are very grateful and must thank you all, especially His Excellency the Governor. In the very beginning, His Excellency, luckily for us, is a medical doctor, and he understands exactly what's health insurance, what is universal health coverage, and he started it firmly, and forcefully. And he is the one that gave the name Health Insurance. We said by saying Health Insurance Agency, but His Excellency on his own sheet to commission, and he told us he wanted to have some powers, some force to be able to run very smoothly. And I'm happy today that the National Health Insurance Scheme have now moved from scheme to authority. And they've moved from Executive Secretary to DG, obviously following the steps of His Excellency, the Governor of Delta State, what he saw many years ago and he put in place. Because we were given a free hand, enough force, policy force to work. And that have helped us tremendously. Having said that, I would like to mention two things. My brother from Kwara, you said two things. How is Delta doing it? How come you're able to survive it? First, the governor. First, the governor. Complaint goes to the governor against us. He reviews it. Oh, hey. Who is that? This is my guy from Lagos. He is the governor, is number one. Once the governor has a political will to drive it, and he wants to drive it, he will make the money available to drive it. And I remember I told His Excellency the very beginning that health insurance is like a nuclear reactor. If you don't want to run a nuclear plant, you don't have the means to run it continuously, non-stop, don't start it. And so because health insurance profit margin is very low, if you delay, like my Commissioner for Information just said, payments and other things, it crumbles. And so now, cash flow and debt payment. I'm very happy you mentioned this issue of paying interest when you delay providers' money. I also want to add the source of the inflow to health insurance from government, from partners, from other sources must not also slow down. If government did not pay his own contribution, and then also we're also going to ask for interest from the government. Because the more flow is a flow, it's like a river. It flows in and it flows out. If the flow coming in is slowed down or stopped, we can't pay the providers. And that do happen from time to time. Luckily, we're able to do a savings. Remember, the premium is divided into segments. There's a segment for pool set aside. The fund we set aside, we don't need to touch, about 5% of the premium paid. And that have helped Delta to flow even when the fund from government has not come in. But we want to say here, His Excellency, the governor representative that is here, that we want to appeal that should be continuous flow regularly so that we can pay the providers that are complaining. And my Kwara brother, that is important. You must discuss it with the source of your flow, and the flow must not stop, must not reduce. Otherwise, you have a problem. Then community resistance. That was a very serious problem at the very beginning. He was in the office of the Commissioner for Economic Planning that we started it. Even the primary care agency resisted it. They believed that we're trying to convert their primary health care centers to private business. We discussed and discussed. Luckily, we have some people in government who are very understanding of the scheme. One of them, Dr. Kingsley Emu, is a man of doctor, not a medical doctor, mind you. He's a book doctor, Harvard We can't count them any masters and PhD everywhere, but it's on finance. That's why the economic finance advisor to the governor. The resistance is great, but we started this way. First of all, we ensure that all the traditional rulers in Delta State were gathered and we spoke to them one-on-one, like in this room. We brought all the traditional rulers of Delta North to Asaba. We met with them. We discussed this scheme with them. We moved to Delta Central. All the traditional rulers came in. We did, and Delta South. Secondly, we invited two persons from each village in Delta State, no matter how remote the village is, to Asaba, to Ugele, and to Warri. And we discussed this issue, this scheme with them before we started, health insurance scheme. What does it entail? And we advised them to go back and discuss with their community. The occasion we even go to the communities with town criers to inform them, to discuss with them. And the first thing we did in Delta was to give all traditional rulers our ID card, free. The scheme ID card was given to all traditional rulers as an ambassador of the scheme. So people must buy in. It is the people, the grassroots you want to serve. And the traditional rulers and the community leaders, president and secretary of the communities are the owner of this scheme, are the owner of the primary health care in their area. So therefore, by the time you go back and say you want to improve on the primary health care center, they are unlikely to refuse you. In fact, the local government system, chairman and so on, refused. But